Good evening, people. Am I audible to you? Good evening, Arun Kumar. Good evening, Azhar. Good evening, Samir Sheikh. Thank you very much for joining me at such short notice. Thank you very much. Yes, Rishabh Gupta, life is good. Riju, Alex, Jeeves, all of you, thank you very much. And there was a 3-minute delay, sorry for that. So, yes, I think I am getting better. I hope I can stay better. So, let's begin. You are actually facing the exam of your life. NEET PG is a very important exam for you. But that doesn't mean it is everything in your life. Do not get stressed. I want to begin this session by saying that if you have put in a lot of efforts in the last few months or last few days, the efforts will not go anywhere. Whatever you do in the world or in the universe, your efforts will always get you effects. Results are bound to happen. The result may be delayed, but it can't be denied. And remember one thing, you are going to be a winner. It may take some time, but it may not actually go away from you. This NEET PG exam, I want you to get the best. That is why I'm taking time out to make sure that you will be able to use this session. Are you able to see this video? Yes, thank you, Sipping Barla, Viraj, Jeeves, Rishabh Gupta. Thank you very much. Are you able to see this? Thank you, Rishabh Gupta. Excellent. So we are having 100 PYQs, clinical MCQs and images marathon. This marathon should set you straight. If at all you are deviating, that is the most common problem faced by students according to my inbox messages is that I have received almost 190 messages in the last 5 days. I was not keeping well and I was not able to answer almost 30 to 40 of the messages, but for all those people, please don't feel bad. I didn't reply to your messages. I'm just giving you this information here. The most common complaint given by students is that when they are sitting to study something, they become very scared. They stop that topic and they jump to another topic and keep on jumping from one topic to the other. That is what is actually breaking their pattern. Do not worry about this. It is very common. If at all your exams are coming up and it's a very important exam, you all have to realize one thing. You have faced all these things already. When you went into first year MBBS, the first year MBBS university practical exam and university theory exams were very, very scary and you did not know what to expect. So what you're having right now may be 10 to 15 times more intense than that, but you have gone through it, you have survived. If you have passed anatomy in first year, you are great. If at all you've passed anatomy, physiology and biochemistry in first year, you are triple great. So you have to understand you have survived that. We all are survivors. We all have passed. Please remember you can pass through this phase also. So if you're feeling less of hunger, more of anxiety, more of tremulousness, more of tremors everywhere, and you are getting angry with everyone and you are not able to focus on anything, it's okay. This is how an exam going student should feel. Do not worry about anything at all. The first and foremost thing I would want you to understand is when you pick up a topic, read carefully. Whatever you're reading, trust it, because no information is a waste of time. But how do you choose which information to study? By going for high yield areas. High yield areas means what? Going back to previous year questions is one of the best methods of going for high yield areas. What does it mean? Pick up a previous year question. Try to look at the answer. The answer may look very simple. Mark my words, this is where many people are making mistakes. When the previous year question is looking very simple, they think it is very beneath their level. They think it is below their level of preparation, so they'll just skip it. They want to look for tough questions. Please understand, if you have 200 questions in your question paper, the question papers, each question carries the same number of marks. Just because it's a simple question, it does not carry less marks. Because it's a very complicated question, it does not carry more marks. So you have to trust every single question and do not make mistakes in the simple question. Those people who are in the mid-range, though are having a lot of negative marks, are those people who are making simple mistakes in simple questions and they come out as silly mistakes. They come out and kick themselves. Do not do that. If it's a simple question, think twice before you choose the answer. Do not be so skeptical skeptical or cynical in choosing an answer, and don't be very casual about it. Give it the due respect. Read the questions properly and then answer. Now what I'm going to show you is a mixture of all PYQs, but modified with a lot of images and some kind of concepts. So I can promise you one thing. Out of 100 MCQs we are going to deal, 100 plus or 100 plus 5, whatever the MCQs we are dealing, I'll tell you the answer, I'll tell you the surrounding information, I'll tell you at least 2 concepts with that. So ultimately at the end of the session you can have 500 facts and 200 concepts and 100 answers. So with this you can directly go to your exam. Do not feel worried about anything else. Please keep your mind focused on this session. Do not worry about anything else. Shall we start? Yes, thank you very much. Yes, Priya. Yes, thank you very much, Priya. Thank you, MNAT Health Center, Himalini. So, shall we begin? And before we begin, let me tell you, I'm Dr. Meenakshi Sundaram, NEET PG educator, and I'm a gold medalist in MD exams and MBBS exams, and I'm a high-octane educator for biochemistry and microbiology for the past 11 years, and I have placed successfully all students into the top 10 institutions in the nation, like AIMS, JIPMER, PG, Chandigarh, and NIMHANS, so you can trust what I'm telling you. And there is a plus subscription on Unacademy. You can use Dr. ASM Live. Yes, you can use Dr. ASM Live to, if at all you would like to subscribe for Unacademy for 1 month or 2 months, you can use this code. And there is an iconic subscription for the Unacademy and Prep Ladder combination, and you can have 10% off on Unacademy subscriptions using this code and exclusive access to all my classes. And these are the recorded and live classes, and these are the iconic subscriptions. These are the special class features: interactive, polls, raising your hand, never missing a class, lecture notes, anytime, anywhere. Okay, and there is a highly effective question bank. These are our proud star learners who have actually scored very well in the FMG exams, and we have 2 fast upcoming batches, Focus FMG batch and next 2022 batch, where I'll be a teacher for you. And this is a NEET PG 1 month package, and there is a grand test series going on. So the next test series will be on 9th, that is the upcoming in 2 days, and you can boost your preparations like this, and you can use Dr. ASM Live for subscription. So let's begin. The first question. Thank you for asking about my health. I think my health is slightly getting better. I'm recovering. So thank you very much. And all of you have prayed sincerely for me. Thank you so much. And yes, thank you. Thank you very much, Arun Kumar. JK, as long as it takes to finish 100 MCQs, approximately 2 hours to 3 hours. So I would like to see you stay with us. Okay, what is the answer? The simplest drug of choice for this condition. What is the answer? Yes. Okay. Excellent. Dr. Sujata Anand has cracked the answer. The diagnosis is onychomycosis. Remember, all these questions are from the previous year questions. I have modified them in such a way you won't be able to look at them as direct repeats, but they are modified repeats. Okay, so please trust the flow, please trust the course of action. At the end of it you will feel good and complete because you're learning a lot. Okay, so DOC means drug of choice for those people who do not know, but we're asking for simplest drug of choice. Remember, if you have a fungal infection, the first drug you have to choose would be always terbinafine. Please make a note of this. Terbinafine is a very important drug that you have to choose. Now if you all like it, yes, if you all like it, we will actually discuss about the antifungal agents also. Is that okay for you? In a small table, in a small picture, we'll discuss antifungal agents for you if at all you feel comfortable. Okay, so please start with terbinafine, and if at all it does not function, then you can go for itraconazole. This terbinafine will be given for approximately 6 months because it's a foot. If at all it is in the hands, you can give it between that of 2 months to 4 months, but once it goes into the toes, it is very difficult to clear them off. So for 6 months you have to give the therapy. And remember, what is the first thing you have to do? Yes, what is the first thing you have to do before you start itraconazole? Can anybody tell me? Because these are the clinical based questions they can ask you. What will you have to do before starting a patient on itraconazole? What is your answer? What do you have to do? Yes, please remember, if at all you have to start a patient on itraconazole, no, not just nail clipping, you have to put the patient on liver function tests. Please understand, itraconazole, the more you use it, the more deterioration of the liver function happen. If a patient is already on poor liver functions, you're not supposed to give it. Remember, amphotericin B should not be the first choice of your drug, and this amphotericin B should not be given for renal failure patients. So I hope you remember this already. Okay, yes, liver function test. Very good. ECG can be done, but primarily liver function test should be done. What are the things you have to know? Onychomycosis is actually a dermatophyte. Remember, onychomycosis can cause brittle nails. It can cause brittle nails, and it can cause deformed nails, and also it can cause discolored nails. And remember, what is the reason for discoloration? The point is, you have two important reasons. One is abnormal melanin. Abnormal melanin accumulation to the local area. The second thing is the hyphae of the fungi. Hyphae of the fungi themselves can actually be the reason behind the dirty color. And recently developed antimycotic agents like fluconazole, itraconazole, terbinafine can offer high cure rates, but they have good safety profiles also. Let's go for the next question. Which of the following antimicrobials should not be given to the chronic asthmatic patient managed on theophylline therapy? See, as I promised, we'll be discussing microbiology as a subject. We'll discuss bacteriology, mycology, parasitology, protozoology, helminthology, and that of virology. Apart from that, we'll do antimicrobials. Then we'll look at clinical infections from different kinds of clinical sources also. With that, it can be very helpful. Excellent. Tanasha, the screen is not clear because you will be requiring high definition. Please put the video on high definition, because even I am not able to look at it if I do not use the quality. The quality should be given as higher picture quality. Okay. Excellent, Dr. Shi. So you are looking at a drug which is capable of inhibiting cytochrome P enzymes. So that answer would be erythromycin. A simple question. The drugs which inhibit theophylline metabolism are, whenever you use erythromycin, ciprofloxacin, and oral contraceptive pills, these all can inhibit the breakdown of theophylline. They can inhibit the breakdown of theophylline. So when you are using these drugs, normal concentrations of theophylline can become abnormally dangerous. So you have to reduce the drug agent to 2/3 of the normal dose. Yes, very good, Sujata Ananda Nazar. Very good answer. Excellent. Next, mechanism of resistance to penicillins via beta-lactamase is. What is the answer here? Excellent. It's a very simple question. So before we go to the next one, let me just put you one thing. See, in case of drug resistance, what are the most important questions they can ask you? If this is a gram-negative organism, gram-negative organisms has higher chances of becoming drug resistance faster. I repeat once again, all gram-negative organisms can develop drug resistance multiple times faster than gram-positive organisms, except in case of Staphylococcus aureus, Enterococcus, and Mycobacterium tuberculosis. Let me give you the reasons. Please take note of this. Staphylococcus aureus, through bacterial genetic transfer of information, it uses both conjugation and transduction. It uses transduction 80 to 90% of the times and conjugation 10 to 20% of the time to acquire drug resistance, and it happens also through plasmids. Now, why is Enterococcus capable of being drug resistant? Because it is inherently drug resistant. Inherently drug resistant means what? No matter what kind of drug you throw on the Enterococcus, there is not much of a target inside the Enterococcus. Generally, all gram-positive organisms may contain a drug binding protein. If I throw an antibiotic, the antibiotic should bind to a protein. There is no target in case of Enterococcus. So Enterococcus is inherently drug resistant to any kind of drug, so it can easily become multi-drug resistant also. MTB goes for mutation. There are so many genes in MTB which can go for mutation. The most common ones are CAT-G genes and RPO-V genes. CAT-G gene will be coding for the catalase enzymes which are important for activating isoniazid. RPO-V gene is meant for rifampicin resistance. So CAT-G mutation can lead to INH resistance. RPO-V gene can go for rifampicin resistance. Let me put my statement once again forward. Gram-negative organisms can develop drug resistance faster than gram-positive organisms, with the exceptions of Staphylococcus aureus and Enterococcus. MTB can be considered as gram-positive, but it is mostly acid-fast organism. I hope this is helpful for you. Yes, did you understand this? Also remember one more question. If they ask you, in case of INH use or toxicity, why is there peripheral neuropathy? Remember, INH inhibits an enzyme called as pyridoxal kinase. This pyridoxal kinase is important for converting pyridoxal or pyridoxine into pyridoxal phosphate. Pyridoxal phosphate is the active form of B6, and this B6 is important for neurological function. So remember, you have to require INH. INH can inhibit the enzyme pyridoxal kinase. Okay, let's move forward. Now look at this particular question here. In case of drug resistance, what are the different mechanisms you have to know? One is altered targets. If I try to attack a particular organism and there is a target here, if this target changes into something else, then this target will not accept the drug, because of which the drug is a failure. Second is failure of proximity. Remember, failure of proximity. What do you mean by that? If I throw an organism here and a drug here, if both of them are having a considerable amount of distance between them, then the drug will not be accepted by the organism. Drug fails. Also, if the influx of the drug is not happening, that also is capable of causing resistance. For example, you have biofilm formation. In case of organisms like Staphylococcus lugdunensis, Staphylococcus aureus, Pseudomonas, Klebsiella, 4 major organisms, if the organism is surrounded by a biofilm, the biofilm can act as a barrier between the organism inside and the antibiotic outside. The antibiotic will not be able to penetrate inside, so there is no proximity, there is no adsorbance, because of which you will be having a drug failure. Third is drug breaking enzymes. Drug breaking enzymes. Now in the question what you saw was penicillinase group of drugs. The penicillinase or beta lactamase, simple words are penicillinase. These will break the drug structure. Let me show you a picture here. Can you see this? What is the mechanism of beta lactam? Beta lactam will actually inhibit the enzyme transpeptidase. Now, blockage of transpeptidase activity interrupts cross-linking and cell wall synthesis. I repeat once again, if for example, you have peptidoglycans, that is, you have peptide components, glycan components. Now, if I bring one more peptidoglycan like this, they are like two L-shaped structures. This L-shaped structure should bind with this L-shaped structure and they have to form a bond. Now this is done by the enzyme transpeptidase, and transpeptidase is not capable of acting right now because of the drug called as penicillin, and that penicillin is broken down by penicillinase group of drugs. That's all. Okay, now let's look at the next question. Fluoroquinolone that is contraindicated in liver diseases, which one? Yes, very good. And I can tell you one more barrier between an organism and the drug. In case of Staphylococcus aureus, there is an enzyme called as coagulase. Coagulase converts soluble fibrinogen into insoluble fibrin meshwork. Now, for example, if this is the organism, all the fibrinogens will turn into fibrin meshwork. That fibrin meshwork can also prevent the drug from entering inside. That is also a method of drug failure. Okay, let me erase this. Coagulase of Staphylococcus aureus. Now, what is the answer of this question, people? Okay, the fluoroquinolone contraindicated in liver failure would be pefloxacin. Excellent answer. Many of you had given B. Very good answer. B is the right answer. Pefloxacin is contraindicated. It has a longer T-half. That is the whole reason. T-half is very high. And what happens when you go for multiple dosages? For example, you start with a loading dose. Then you have to go for a maintenance dose. Maintenance dose should be given at regular intervals. Because it has a very long half-life, the repeated dosage will cause accumulation of drug. And the concentration, what is the line? What is the single line you have to know? The accumulation of the drug will lead to 2 times expected concentrations compared to other drugs. And it is effective in systemic infections. It is effective in systemic infections, but it can be very dangerous in case of liver disease. because liver has to eliminate the drug through fecal material, and it is not sent through urine, it is coming through feces, and it can be used in case of renal insufficiency. Okay, let's go for the next question. Drug of choice for invasive aspergillosis is, what is the answer? Drug of choice for invasive aspergillosis is? That is what exactly I said, Jeeves. It is metabolized in the liver, so it has to come through liver. If it is liver, if there is a liver failure, it can't come out through the fecal material. Liver has to metabolize it. That is what I said. What is the confusion? I said exactly what you said, Jeeves. Yes, the drug of choice for invasive aspergillosis can be? Yes, please choose voriconazole. You do not have to go up to liposomal amphotericin B. Remember, amphotericin B should be taken as a last resort kind of drug. And even though it is liposomal, still it can have an effect on the kidney. It can cause kidney failure. And if they ask you what kind of electrolyte imbalance it can cause, the answer would be hypokalemia. The answer would be hypokalemia. Okay. And look at this, the preferred treatment of primary invasive aspergillosis voriconazole, and it is superior to amphotericin B. Azoles interfere with the synthesis of ergosterol found in the fungal cell membrane, whereas polyenes such as amphotericin B interfere with the ergosterol function. So this is the difference I would want you to remember. Ergosterol function can be disturbed by amphi B, while you will be having synthesis of ergosterol. Synthesis of ergosterol is being inhibited by your drugs like azoles. And in case of fungal cell wall, it can be caspofungin, echinocandins, etc. Okay, so for those people, yes. For those people who would like to know about this, can you please look at the picture? Is the picture visible to you people? This is one common picture taken from researchgate.com. Can you look at the picture? Is it visible? Please tell me if it is visible for you to read. Yes. Now look at this. See, first you look at a fungal cell. Because a fungal cell is a eukaryotic cell, you have to understand it contains almost similar organelles like how in case of a human cell. It can contain mitochondria, it can contain nucleus. Now look at the part here, we'll go from outside to inside. If it comes for cell wall, the cell wall is made up of chitins and glucans. Please remember, it is made up of chitin and glucan. It also can contain manoprotein in some kind of fungi. Now you have a particular drug called as echinocandin. That group of drug will cause cell wall disruption by inhibition of 1,3-beta-D glucan synthase. So echinocandins, caspofungin, anidulafungin, all these things are capable of inhibiting 1,3-beta-D glucan synthase. They can cause cell wall disruption. At the same time, you can have 2-beta glucan synthase also being inhibited. Next, you have unconverted 1,3-beta-D glucan if at all this drug echinocandin has been used. Then you can look at the cell membrane. In case of cell membrane, which is actually gray in color as you see, you can have the ergosterol being synthesized being blocked. First, ergosterol synthesis can happen through inhibition of 14-alpha-D-methylase with the help of azoles. Production of ergosterol is inhibited, accumulation of a toxic intermediate sterol can happen. I repeat, not just the production of ergosterol is inhibited alone. Ergosterol inhibition is not the only problem. Because of inhibition of 14-alpha-D-methylase, a precursor sterol will be accumulating. That precursor sterol can actually cause membrane stress and can cause destruction of the membrane. Also remember, there are allylamines which can inhibit the enzyme squalene epoxide, because of which ergosterol inhibition happens. But allylamines will be acting at a higher level, because of which toxic precursor is not accumulating. So when they ask you, among the drugs which are inhibiting the ergosterol synthesis, who can introduce a toxic sterol intermediate, the answer would be for azoles. Now look at this part. Those drugs which are capable of inhibiting microtubules. For example, mitosis inhibition can be done by griseofulvin. mitosis inhibition is done by griseofulvin. Microtubule assembly can be inhibited or spindles can be inhibited. So what happens if they ask you what is the result of mitotic spindle being inhibited? The answer would be blocking of cell division in the metaphase. This is an MCQ. Please take a note of this. Blockage happens in the metaphase. Next, look at DNA RNA synthesis. Fluoropyrimidines can be used here. Now look at this part that is acting at the level of nucleus. Squalene epoxidase is inhibited by allylamines. Ergostol synthesis pathway is inhibited by azoles with the 14-D-alpha methylase, alpha demethylase. Now look at this part. The fluoropyrimidines can cause inhibition of the DNA or the RNA synthesis. Inhibition of DNA synthesis, inhibition of protein synthesis, both can happen. The answer would be fluoropyrimidines. So this is one quick revision of all the anti-mycotic drugs. See, sometimes YouTube, it goes for automatic low quality. You can click for higher resolution. You can click for higher resolution if you're not able to see it. Okay. So have a look at this part. This is also showing you different forms of activity. Polyenes mechanism is it can actually cause pore channel formed by amphotericin B resulting in cell death, and you will also have a drug called as flucytosine. Let me zoom it for you. I'm zooming this for you. Now 5-fluorocytosine can actually go for cytosine permease. This 5-fluorocytosine will be acted upon by cytosine deaminase. It becomes 5-fluorouracil. It can actually become FUMP and FDUMP. If it is FUMP, it is inhibiting protein synthesis. If it is FDUMP, it causes inhibition of DNA synthesis. Okay. Lanasterol to zymosterol synthesis can be inhibited by azole action. Okay. Now let's go for the next question. Which of the following drugs act by inhibiting the transcription of DNA to RNA? What is your answer, people? Which of the following drugs act by inhibiting the transcription of DNA to RNA? Yes, it's a straightforward, simple question. It is rifampicin. What exactly rifampicin does? See, you have a DNA. A double-stranded DNA will become a single-stranded DNA. From the DNA, you have to go for mRNA synthesis or RNA synthesis. This RNA synthesis will be called as transcription unless if it is a replication of an RNA. And that particular statement is rifampicin is exhibiting destabilizing effect on the binding of the intermediate oligonucleotides to the active enzyme DNA complex. See, in the DNA, the RNA polymerase enzyme will be rushing through. Now, this RNA polymerase enzyme, as it binds here, it tries to accept oligonucleotides. Oligonucleotides, not deoxyribonucleotides. It is oligoribonucleotides because you're going to synthesize RNA. And when the nucleotides are supposed to come in, they are hindered by coming inside. And that is because of the beta subunit of the RNA polymerase being inhibited. And can only interact specifically the RNA polymerase if the enzyme is free or in the binary complex with the DNA. Remember this statement. This is an important concept. RNA itself can only interact. How? If the enzyme is either free or if the enzyme is bound to the DNA molecule directly. Only two conditions. Okay. What is a vector for Zika virus? What is a vector for Zika virus, people? It's a simple question. Let me show you a different picture that was asked in the exams. I will show you the direct picture taken from November 2020 INICET exam, the same picture as given by students. Okay, almost all of you are saying Aedes. The answer is Aedes. Look at this. This was the picture shown in INICET. Can anybody recall this picture given in your INICET exam? Do you remember this picture from the INICET exam? Okay, let me tell you the most important parts. Aedes mosquito is the one who spreads Zika virus, and it can go for transplacental transmission. This one picture can give you 4 concepts and different kinds of data. First concept is that the Zika virus shows transplacental transmission and can affect the developing fetal brain, because of which you can expect microcephaly. Also, the Zika virus is capable of being accepted by the Langerhans cells, and when the Langerhans cells, they actually multiply. Langerhans cells are a type of reticular endothelial cells from which the viruses can multiply, and they can go for viral dissemination. Also, Langerhans cells are trying its best to give you protective immunity, but not possible, and they can trigger melanocytes, because of which pigmentation can happen in certain patients. Point number 1. Next, you can look at this particular activity. Yes, look at this particular activity. In the chorionic villus, it specifically affects half-Boyer cells, syncytial trophoblasts and cytotrophoblasts. When they ask you what are the molecules that have been involved, I repeat once again, Zika virus replication can happen in case of this ISGs. Let me erase this. I'll zoom this for you. Zika virus replication can happen in this cell, and Zika virus restriction can happen in this cell, syncytial trophoblasts. And IFN lambda 1 is the involved marker. IFN lambda 1 is the involved marker. I repeat, in the half-Boyer cells, Zika virus replication can become very huge. Next, it can also affect your radial glial cells, and it is capable of causing neurogenesis inhibition. And what does it bind to? It binds to AXL receptor. See, don't take this information as extremely difficult information, but these are the additional informations to be known by you in case they ask you a question. I told you, right, high yield questions are definitely supposed to be high yield area information. Why? Because when you learn a question and the surrounding information can become a very important target for the upcoming exams. That is why I'm telling you all these things. Is that okay if I tell you all these things, or am I depressing you? See, if you feel like I'm depressing you, please let me know. I won't go into the details. I'll just give you some questions and simple answers to them. Please tell me faster. Okay, so when they ask you half-Boyer cells, Zika virus replication, in syncytial and cytotrophoblasts, Zika virus restriction, and what is the receptor in the brain? In the neuronal cells, AXL receptor accepts the Zika virus. Okay, so in the Zika virus, the receptor would be AXL receptor, and which kind of receptor they can actually involve in? Toll-like receptor 3, TLR3. And when they bind to that, they can cause inhibition of neurogenesis regulators, and they can inhibit and they can activate apoptosis. When the brain is automatically shrinking, when the brain is not increasing in size, then the skull space required for such a small brain is also smaller. I repeat, when the brain is shrinking, when the brain is not reaching up to an optimal volume, then you don't need such a kind of skull. So the skull volume also will start shrinking, because of which you will be having microcephaly. These are the data I would want you to know. The mosquito would be Aedes mosquito. Have a look at this. It is spread to people primarily through the bite of an infected mosquito. It can be Aedes aegypti or Aedes albopictus. Please remember, there is one more aegypti. It is Haemophilus aegypticus, and this is a bacteria. Many people got confused when they were talking to me. Some of them got confused between that of Aedes aegypti and Haemophilus aegypticus. Haemophilus aegypticus is known for causing Brazilian purpuric fever. It is known for causing Brazilian purpuric fever. Haemophilus aegypticus is actually a bacterium. It is known for causing Brazilian purpuric fever. Now remember, Zika virus can be an STD. It can be spread through sex. Please remember this part. And what are the other things that can be spread by Aedes? It can spread dengue and chikungunya viruses also. Is that clear? Okay, next, look for the next question. Yes, very good approach, Azhar and Sai Arvind. Thank you very much. Okay, now look at this picture. All are true regarding Japanese encephalitis, except, what is your answer? The Nipah spread in a sexual manner has not been properly reported. Not many people have data about this. It generally spreads through fruit bats and saliva from the bats. Excellent. So it is Japanese encephalitis virus, JEV. It's a type of a flavivirus. Remember one thing, flavivirus is a taxonomical classification, while arbovirus is a relative classification based on spread. R stands for arthropod and BO stands for borne. So they are vector bitten arthropod borne virus. So JEV is both a flavivirus and an arbovirus. Can anybody tell me what is the mosquito? The mosquito would be Culex mosquito. Humans are dead-end hosts. Why? Let me tell you the concepts here. It is caused by a flavivirus, of course. Why human beings are dead-end hosts? Because pigs will be amplifier hosts. When the Culex mosquito bites a pig, the virus is sent into the circulation of the pigs. In the circulation of the pigs, the viral load will become very high. Viral load can become very high. So when a virgin mosquito comes and bites a pig who is already infected, the pig can actually offer higher load of viruses to the new mosquito, because of which a newer mosquito can carry more viruses from the pig and go back and bite a human being. In the human being, the primary viremia may be moderate. The secondary viremia is not very high. So the circulation of the human beings will not be containing high viral loads. Instead, the virus in the secondary phase can go and bind to your brain and can cause encephalitis. And when the human being dies, he dies as an individual host. If a mosquito comes and bites a human being, the mosquito will not be able to extract a lot of viruses from the human being. So human beings are dead-end hosts. They are not capable of spreading to others. And cattle are not the amplifier host. It will be the pigs. And remember, R-deed birds are important reservoirs for Japanese encephalitis. And what are the most important things you have to know? It is a zoonotic disease. Incidental host is man. And what are the epidemics happening? The epidemics have happened in most of the South Indian states like Karnataka, Andhra Pradesh and Tamil Nadu and Kerala. And human, cattle and horse are all dead-end hosts. I repeat, humans, cattle, horse, all are dead-end hosts, because in all the three animals it can cause fatal encephalitis. And pig is the only one that can act as an amplifying host, and infection in swine is asymptomatic. The pig will not know that it is suffering from that of the infection. And what is the vector? Culex tritanio-rhynchus. And in case of South Korea, it is Bitanio-rhynchus. I repeat, in South Korea, it is Bitanio-rhynchus. In November 2011, it was discovered. It was reported. And who are the natural hosts of the virus? It is Japanese encephalitis virus. The natural host would be R-deed birds. See, with one single disease, in a matter of just 3 minutes, we have discussed a lot of information. Are you happy with this information? Are you happy with this? Okay, so let's go to the next question. All the following is or are having superantigen property except. What is your answer? The answer is not technically D. Vibrio cholerae generally is not supposed to show you superantigen property. Now let me list the superantigens. I'll write it here for you. The most common superantigens can be divided into bacterial and viral. In case of bacteria, in case of streptococcus and staphylococcus, the common one would be pyrogenic exotoxin. It is exotoxin C of staphylococcus and A of streptococcus. Then we can have something called as toxic shock syndrome toxin belonging to both streptococcus and staphylococcus. 1, 2, present in both streptococcus and staphylococcus. What is unique for staphylococcus? You have a staphylococcal scalded skin syndrome toxin, also referred to as exfoliatin. This exfoliatin can cause sudden exfoliation, almost like Nikolsky sign. you can expect a Nikolsky sign positive because of sudden loss of the skin. You can have the whole skin falling off. Now that if it is happening in the adults, it's called as toxic epidermal necrolysis. If it is happening in children, it's called as Ritter's disease. Also, Staphylococcus aureus enterotoxin. So let me use a highlighter here. Pyrogenic exotoxin belongs to both Streptococcus and Staphylococcus, and toxic shock syndrome toxin also belongs to Streptococcus and Staphylococcus. While if you focus on Staphylococcus only, the staphylococcal toxic shock syndrome, staphylococcal scalded skin syndrome toxin, and enterotoxin. These are the bacterial superantigens. Who are the viral superantigens? Have a look at this. You have murine mammotrophic virus or mouse breast cancer virus, and you have rabies virus associated superantigens which can promote viral transmission. We have EBV associated superantigen, we have measles associated superantigen, we have HIV associated superantigen, we have CMV associated superantigen. The CMV associated superantigen is capable of enhancing HIV-1 replication. EBV associated superantigens can have oncogenic potential, and remember, oncogenic potential can be a property of both mouse breast cancer virus and EBV. And remember one more thing, non-human retroviruses also can exhibit superantigenic property. Okay, rabies, CMV, EBV, and mouse breast cancer virus and non-human retroviruses, some HIV antigens. Is that clear? Okay, so what is type A bioterrorism agent among the following? Among the following, which one is the type A bioterrorism agent? But the question is slightly wrong. It should have been category A or rank 1. See, it is not chikungunya. Of course, it is anthrax. All of you should be knowing this. This is a very commonly repeated question. This has been repeated 16 times in the last 10 years. And look at this part. This slide can be slightly difficult to read, so I'll zoom this for you. Look at this. What is category A? It poses the highest risk for national security. Why? Because they can be, see, you have to know the properties. It has highest dissemination, high mortality rate. They have the potential to cause public panic. The most important word for any biowarfare agent. Terrorism means not just killing. Terrorism means inducing terror in the minds of people. So public panic. Next, it has to have requiring special preparedness actions. What about B? B will be second highest risk because they are moderately easy to disseminate and low mortality rates. It requires enhancement of diagnostic properties. So remember, in case of A, the requirement is special preparedness for dealing with the high fatality. But in case of B, it is important for diagnostic surveillance. And what about C? They are emerging pathogens. You still have to work on them. And they are easily available, easily produced and disseminated, potential for high mortality rates. See, just because it is category C, it does not mean low mortality. This is what I want you to remember. In C also, you can have a potential for becoming high mortality. Potential means what? Right now they are not causing high mortality, but it can be engineered, it can be converted, it can be modified to become high fatality causing areas. And what are the best examples? Anthrax, botulism, plague, smallpox, tularemia, Ebola fever, all are category A. Even if you can't remember the other categories, please remember category A. That is a must for every medical student, not just for your exams but also for your real life practice. Anthrax, botulism, plague, smallpox, tularemia, and Ebola, Marburg. In case of B, ricin toxin, salmonella, dirigenic E. coli, caliciviruses are category B. And in case of category C, influenza, SARS, rabies, multidrug resistant tuberculosis, yellow fever, tick-borne hemorrhagic fever. So, for example, when they say SARS is category C, you can understand that by a modification in the laboratory in case of Wuhan, SARS-CoV-2 emerged, and that SARS-CoV-2 was capable of causing high mortality rates. Now, this can be taken as category C. If at all this maintains, it may shift to category A also. Are you understanding this? Excellent. Nipah, Hanta, all these things are having the potential. Remember, the viral hemorrhagic fevers come under category A, but tick-borne hemorrhagic fevers will come under category C. Is that clear? Okay, so let's go for the next question. This condition in the picture is caused by a small request to all of you, because these are the last 4 days, that is 8th, 9th and 10th. We have only 3 more days between the exam after tomorrow, and some of the students may not be aware of this session. If you have a chance, please spread the word that such a session happened. Anybody who spends 3 hours even on 2x, they should be able to use this much amount of information, because all these are the recent repeats and recent modified extra added information from the faculty. It can be very effective. So I would request you to put a thumbs up at the end of the session, and after the session is over, please comment and share. When you comment, more people will be able to see it, so that the karma, the good karma that I would like to give you when I take such a free class, it's to help you. And if you share it and comment and like it, it can be helpful for others. The good karma will always come back to you. For that reason, please put a like if you like the class. The answer would be Klebsiella granulomatis. This condition is called as Donovanosis, and this Donovanosis can also be called as what? Anybody? Yes, this excellent, very good, Sushritanand. This is called as beefy red ulcer. These were the exact words used in the NECT exam. Beefy red ulcer, bleeds to touch. Bleeds to touch. Anybody? Yes, this is Donovanosis. Can anybody tell me another name for this? What is the other name for this? What is the other name for this, people? Yes, it also shows safety pin appearance. Calimacobacterium granulomatis, Yersinia pestis, they all can show safety pin appearance. Burkholderia also can show safety pin appearance. Excellent. This is what I was expecting from you. Granuloma inguinale. This is capable of causing some amount of pain, and lymph nodes may be involved. Now here you have to understand, the older name for the organism was Calimacobacterium donovani. People thought Calimacobacterium donovani is the one known for causing Donovanosis. That is true. There is one more organism called as Leishmania donovani. There is another organism called as Leishmania donovani. This Leishmania donovani was also considered as, some people thought it may be causing Donovanosis, and this was trapped. This was used as a trap by AIMS and NEET PG exams. So people thought Leishmania donovani is known for causing Donovanosis, but not. It is known for causing leishmaniasis. It causes leishmaniasis, cutaneous and visceral leishmaniasis. Now, the Calimacobacterium donovani has lost the name called as Calimacobacterium donovani. It became later called as Klebsiella donovani. Now it is called as Klebsiella granulomatis. This is a newer name in the last 5 years. Let's go for the next question. And this is a sexually transmitted disease. Fungal infection which is acquired by traumatic inoculation is, what is your answer? Excellent, very good. Yes, you can also expect Donovan bodies. I'm so sorry I missed this. You can look for Donovan bodies, but they are not the same as LD bodies. What is LD body? LD body can be seen in visceral leishmaniasis, and they are the amastigote forms. Absence of a flagella. If at all there is no flagella, the organisms became afflagellated. They are non-flagellated and found inside the macrophages. And in the macrophages, neither the macrophage is killed nor the microbe is killed. Both of them will have a deadlock. So inside the macrophages, the non-replicating amastigote form, if they are present, they are called as inclusion bodies, called as LD bodies. Dominant bodies are not the same as LD bodies. Let's look at this question. The answer for this would be a very common question. It has been repeated 7 times in the last 3 years. It has been repeated 15 times in the last 7 years. And the questions have been repeated left and right. I think they might get bored of this particular area. So what are the most important things that you have to know? Sporothrix belongs to a group of organisms causing, please listen to this, this is very, very important. It belongs to a group of diseases referred to as subcutaneous mycosis. Please take a note of this. This is very important if you have not prepared mycology well. If you are done with this, just be patient for the people here. One is mycetoma. Next is chromoblastomycosis, phaeohyphomycosis, rhinosporidiosis, and sporotrichosis. These are the 5 major subcutaneous mycosis causing organisms. So if it is plural, it becomes mycosis, out of which rhinosporidiosis caused by Rhinosporidium C. berry has been knocked out. Why? Because Rhinosporidium C. berry was initially called as a fungi or a bacteria, but now it is referred to as a freshwater protozoa. Okay, this is referred to as a freshwater protozoa. Now among these, what is the basis for causing subcutaneous mycosis? Why are they not causing superficial mycosis? Remember one thing, superficial mycosis causing organisms are those who can have the enzyme keratinase. With the help of keratinase, they can destroy the keratin layer in the skin and they can cause debris of keratin. Through the gap, they can actually stay happily and can enjoy the benefits of the dead skin. But these subcutaneous mycoses are not capable of penetrating the skin. Then how are they able to go below the level of the skin? The most common thing among all the diseases would be a prior, sharp or blunt penetrating injury. Penetrating injury is common for all these diseases. Only then they are inoculated inside. Inoculation means the spread of the organism by a mechanical agent. Somebody is actually poking through the skin. Through the same track, the organism is also sent inside. So all these of them are inoculated. I hope you understood the logic. Did you understand this? So blastomycosis, coccidioides, paracoccidioides, histoplasma. These 4 are referred to as systemic mycosis causing organisms, and they will be known for endemic mycosis. I'll give it in very short words. Look at this part. See, blastomycosis is known to attack North America. Coccidioides is known to attack your valley called as, coccidioides is known to be causing desert rheumatism, valley fever, especially in the Colorado Plateau. These are all golden information you have to know. Paracoccidioides is known to attack Brazil, so it is South American. I repeat, blastomycosis is North American, coccidioides is desert rheumatism or valley fever, Colorado Plateau. Paracoccidioides is South American. Can anybody tell me who is known for causing European? Yes, who is known for causing European? European is caused by whom? Anybody? It's okay if you don't remember, I'll write it here. Cryptococcus. Though Cryptococcus is not a dimorphic organism, but in case of immunosuppressed people, it can become systemically disseminated. European is caused by Cryptococcus. Please take note of this. So let's go to the next part. This was the exact picture given in the recent exams. This is the recent exam picture. When they ask you, what is the source of nutrition for Sporothrix? How do they describe Sporothrix? You can have painful or sometimes painless ulcero-nodular eruptions along the lines of lymphatics. Yes, I have told them in many classes. I have told you this in many classes. If you are looking at lymphatics, the lymphatics will actually be carrying triglycerides. So triglycerides are very important source of nutrition for Sporothrix skinki. And what are the most important words you have to know when they speak about gardeners, when they speak about Himachal Pradesh or Shimla or any kind of hill station where rose plants are present. The rose thorns, when they pick, the picking of rose thorns can send in the spores of Sporothrix skinki, through which they can actually cause the granulomatous reaction. Also remember, this granulomatous reaction can resemble Mycobacterium tuberculosis at some level. MTB infections at some level. What are the other things you have to know? Sphagnum moss, rose bushes, horticultural plants are all involved in case of Sporothrix skinki. So I hope you'll be able to use this information. Okay, which of the following is not involved in urethritis? Come on people. These are clinical MCQs. Yes, these kind of questions can be very confusing. Yes, it can be very confusing. That is why I pushed for this question. See, these questions are one-line questions. Remember, lengthy questions are a boon. When you have a lengthy question, the only problem is it takes time to read it. But because you have 3.5 hours, you have enough amount of time to read through it. You don't have to worry about it. When it's a very short question, if you know it, you know it. If you do not know it, you'll never be able to answer it. But it's a long question. Looking at different aspects, you will be able to crack the question at some point of time, right? So you have to understand Haemophilus ducreyi is a clear STD. It is not known to cause urethral inflammation. It is known to attack the skin and the mucosa around the area, not the urethra. Trichomonas can cause urethritis. At the same time, it can cause vaginitis. And chlamydia is known for causing urethritis because the most common cause of urethritis is gonococcus. Remember, the most common cause of urethritis is gonococcus. The next most common cause will be chlamydia. Because gonococcus is so common, if there is a urethritis caused by anything other than gonococcus, it has a separate nomenclature called as NGU, non-gonococcal urethritis. The most common cause of non-gonococcal urethritis is Chlamydia trachomatis. At the same time, you will also be having urea plasma urea lyticum and tuberculosis. These also can cause urethritis. Trichomonas also can cause urethritis. Remember, H. ducreyi is known for causing STD. Let me erase these. Okay, so let's go for the next question. As it causes chancroid. This is how the picture looks like. You can leave these lesions. And remember, Chlamydia trachomatis is sexually transmitted and can cause chlamydiasis. And the painful urethritis, look at this. Most painful urethritis is caused by HSV2. Also remember, if you focus on Treponema pallidum, which causes syphilis, the condition is called as chancroid. If it is chancroid, it is painless. I'm so sorry. I got distracted. I apologize. When you focus on Treponema pallidum, it causes chancre. Chancroid is painful. Chancre is painless. Now, T. pallidum, both the lymph nodes and them are painless. In case of H. ducreyi, the lymph nodes and chancroid, both of them are painful. Now, if they ask you, how do you differentiate LGV? LGV, both lymph nodes and the lesions can be painful. But the difference is, lymph node enlargement and skin lesion, they don't coexist. Do not coexist. When one appears, the other one has still not appeared. But when the skin lesion disappears, only then the lymph node appears. This is a key information for you to use it. Okay, excellent. Now let's go for the, okay, this is, let me reopen the slide once again. The PPT hung because of the load, because there is so much, the PPT hung. Now let's go back to this question. Yes, the patient complains about nausea, vomiting and stomach cramps after attending a social gathering party which causative organisms likely responsible for food poisoning within 3 hours. Yes, what is the answer? Yes, so all of you are well versed in this topic. Let me just give you some information. Look at this question. Nausea, vomiting, stomach cramps after attending a social gathering party. Which causative organism is causing this food poisoning? The answer is Staphylococcus aureus. Remember one thing. Staph, these are the bullet points. Shall I teach you the bullet points in case of food poisoning? Would you want to learn? No. Shubhakalyan Majumdar, it cannot be Bacillus cereus. I'll tell you why. Is it okay if I teach you some points about food poisoning? The most important pointers to make a diagnosis instantly. Okay, look at this. Staph aureus, if they ask you what are the most common sources, it is dairy products. When I say dairy products, you can't go back to the concept of unpasteurized milk. Remember, the milk has already been used as a cooking agent. The milk has been cooked properly and it has been converted to dairy products like curd, cheese, butter, etc. This is point number 1. Staphylococcus aureus uses a heat stable toxin. This heat stable toxin is so stable. There have been questions about this. How stable? It is stable even after boiling for more than 1 hour for 100 degrees Celsius and above. Still, the toxin is very stable. This is a unique activity. At the same time, Staphylococcus aureus mechanism is direct activation of vagus. Direct activation of vagus means it is capable of activating a peristaltic movement. Peristalsis frequency increases, the force of peristalsis increases. Because of continuous contraction, you will be having abdominal cramping. So crampy diarrhea has to be about Staphylococcus aureus. In Bacillus cereus, watch very carefully, in Bacillus cereus you have two types of poisoning. One is heat stable toxin poisoning, the other one is heat labile toxin poisoning. Heat stable toxin happens within 6 hours. The same thing is applicable for Staphylococcus aureus also, attacks within 6 hours. But in case of heat labile toxin, it is more than 8 hours. But heat stable and heat labile toxin will activate and cause secretory diarrhea. And the source of food poisoning will be Chinese food. It is also referred to as Chinese restaurant syndrome causing organism. It is also found in vanilla sauce. These are the bullet points I would want you to know for the exam. Chinese food, vanilla sauce, Bacillus cereus. And heat stable toxin increases the concentration of cyclic GMP and heat labile toxin increases the concentration of cyclic AMP. And they can cause abdominal pain, but you can't name it as crampy abdominal diarrhea. What about ETEC? In case of ETEC, again you have heat stable and heat labile toxin, again increase in cyclic GMP and increase in cyclic AMP for heat labile toxin, and this is one of the leading causes of traveler's diarrhea. There is a confusion between who is the most bacterial common cause of traveler's diarrhea. The answer is ETEC and EAEC, enteroaggregative E. coli. When it comes to EHEC, it is not only releasing an enterotoxin which can cause diarrhea, it also releases cytotoxin which can cause death of enterocytes, and those enterocytes on dying will start bleeding. That bleeding is the reason for dysentery. So you have bloody diarrhea, and the most common source of EHEC would be ground beef, especially hamburgers. Is that okay? Yes. Next we focus on botulism caused by Clostridium botulinum. This botulinum toxin can actually be attacking your presynaptic areas and attacks the synaptophysin and synaptobrevin and blocks release of acetylcholine. When there is no acetylcholine coming to the postsynaptic area, there is no excitation and there is no contraction. There is no excitation, there is no contraction. At the same time, if it is not a muscle, if it is a secretory gland, there is no secretion. Because of absence of secretions in the GIT, at the same time there is no contraction in the peristaltic area at all. Botulism is the only type of food poisoning where you expect constipation and not diarrhea. At the same time, you have to understand botulism is the only food poisoning which can be fatal instantly, and infant botulism part is slightly safer. What is the source of botulism? Tinned food, canned food, which are contaminated by anaerobic bacteria in the anaerobic conditions, and in case of infant botulism it is contaminated honey. Next I'll tell you something about Salmonella. Salmonella enteritidis is the one known for causing food poisoning. Remember, if at all there is a salmonella known for causing food poisoning, that is Enteritis typhimurium. It is not typhi. Typhi is known for causing typhoid. Typhoid is not food poisoning. This salmonella enteritis is coming through poultry and eggs. There was an MCQ. Which bacteria is able to penetrate through the intact eggshell? It can go through the intact eggshell, that is Salmonella. Next, we focus on Campylobacter jejuni. Campylobacter jejuni, Mycobacterium bovis, both of them can come through unpasteurized milk. And you have Yersinia enterocolitica, which can cause bleeding diarrhea. Who else can cause bleeding diarrhea? Salmonella can cause bleeding diarrhea, and Campylobacter jejuni can cause bleeding diarrhea. Now, what is the important thing about Campylobacter jejuni? This can introduce invasive property at times and can also use heat labile toxin at times. Now, there are some people who may misunderstand Vibrio cholerae to cause food poisoning. It is absolutely wrong. Vibrio cholerae is known for causing cholera. Cholera is not a simple activity like food poisoning. Cholera kills you instantly by causing instant dehydration. Vibrio cholerae is not known for causing food poisoning. It is known for causing the king of all diarrheal diseases called as cholera. In cholera, you are actually very ashamed to even call it as diarrhea. It is bursting diarrhea. People will be losing water at the rate of 20 liters per day of diarrhea. People die merely by diarrhea, not by sepsis. And that is what you have to understand. If at all there is a Vibrio that can cause food poisoning, it is Vibrio parahemolyticus, and the source of Vibrio parahemolyticus would be sushi, like shellfish, which is raw or unpasteurized seafood. So remember, I have given you all important pointers about food poisoning. Okay. ACH in botulism. I said in case of presynaptic area and postsynaptic area, acetylcholine which is present inside the vesicles should be destabilized so that acetylcholine can be released into the postsynaptic area where the receptors of acetylcholine will be accepting the acetylcholine. But botulinum toxin will block the release of acetylcholine, because of which there is no acetylcholine on the postsynaptic area, so no excitation. No excitation, no contraction or no secretion. Is that clear? Okay, for those people who want to know about preformed and postformed toxins, remember, preformed means bacteria is there in the food and it is growing to release the toxin. So bacteria plus toxin are found in the food. This is also referred to as intradietic toxin. The toxin is already there inside the diet, and this will generally be a heat stable toxin. That is why when the food is heated, still the toxin is safe. But if it is a post formed toxin, it means the toxin is not there in the food, so food contains the spores and some amount of the bacteria. When the food is ingested, the spores will go for exporulation, and the exporulation will release the bacteria. In the intestine, the bacteria release the toxin. So this will be most commonly a heat labile toxin. Is that clear? Manoj Singh, have I answered your question? Yes, Deepak Singh. When they ask you what is the most potent toxin on earth, it is botulinum toxin. Even 1 microgram to 1 nanogram of the toxin is capable of killing a full-size pig. A full-size pig can be killed with that. Okay. Excellent. So I'm continuously rushing through the topics. I didn't check whether you are all doing okay. Are you all doing okay? See, if you're having any kind of anxiety, please take a deep breath. Whether you believe in God or not, the force of the universe will stay with you if at all you have given a lot of hard work. If you think you haven't worked hard in the last few months or in the last few days, at least do it now for the next 4 days. Do as much as possible. If you do not know where to go and what to do, just look at this session and just listen to the session. Listening to something or doing something with your ultimate focus is called as meditation. Remember, meditation does not mean you close your eyes and you take a deep breath and doing something. When you focus on something very sincerely, that is also called as meditation. Remember, when I walk into the class, I'm having abdominal pain. I feel like I might have have diarrhea and I am having ulcerative inflammations everywhere and maybe having bleeding ulcers, but the pain is not actually showing right now because I feel like I'm in a meditated state. I did not even realize it is 9:14. Why? Because there are so many students who are really lovably listening to what I'm saying, and because you all are going for exams, my ultimate focus is to make you go for exams with this information, and if you use this information directly in the exam, you are going to be a winner. Remember, 100 MCQs, and for every MCQ I'm giving at least 10 or 15 statements, and I'm giving you at least 2 concepts. So if at all you sit with this with me for the next 1 hour or 1.5 hours, you can carry this much amount of information which you can directly use in the exams. Even if 10 things out of these much come in your exams, your rank will be boosted. So that is why I am completely focused. So you focus on the class in such a way, you feel meditating, and whenever that is happening, you will be forgetting about every single noise on the earth outside. That is what is the best that I can give you. So yes. So are you all okay? Yes. Correct. Yes, there is no effect of antibiotics on preformed toxins. Why? Because the bacteria is already there in the food and the toxins are already ready. But if you give antibacterials for food poisoning, what can they do? They can prevent further multiplication of bacteria and further release of toxins. But the best way to treat them would be by giving antitoxins, which are immunoglobulins. Parashuram, I just told you a few minutes back, heat stable toxins act by cyclic GMP. Heat labile toxins act through cyclic AMP. Let's go for the next question. A 46-year-old woman with HIV complains of severe persistent diarrhea. Histological examination was performed. Identify the organism causing diarrhea in the HIV patient. Go. Thank you all of you. Thank you so much all of you. Yes, I got my diagnosis. I do not want to reveal it. It's just a difficult phase, but I think I'll be able to overcome. And for your prayers, thank you so much. I got so many inbox messages. I don't know why you all are so caring. Thank you so much. What is the answer? Yes, Cryptosporidium. Remember, Cryptosporidium parvum. Cyclospora, Isospora belli. All of them are very commonly known to attack HIV patients. And how does the histological picture look? This is how it looks. This is where you're seeing the organisms. What are the common infectious organisms causing AIDS-related diarrhea? It can be cytomegalovirus. Some people might not be thinking about it. Cytomegalovirus is known for causing pneumonia also. Cytomegalovirus is known for causing infections in solid organ transplant patients like kidney transplant patients, and cytomegalovirus is also known for causing retinitis. It is also capable of causing chorioretinitis, and cytomegalovirus is capable of causing increased size of the cell. That is what is called as cytomegalovirus. You can have owl eye inclusion bodies, and remember the parasites like Cryptosporidium, Microsporidia, Giardia lamblia all can become dangerous in causing diarrhea, and Mycobacterium avium intracellular is also capable of causing diarrhea. Now, let me ask you a quick question. Which organism is regularly capable of causing diarrhea and dysentery, but not capable of increasing the frequency or severity in case of AIDS patients? Name the organism. HPE would be a different class altogether. It might take a lot of things. I haven't loaded the slides of that. So, we'll just stick to the topic here. Let's just tell me. Can you name one organism who is regularly known for causing diarrhea and dysentery but does not actually increase the severity in case of AIDS patients? So remember, it can come as a surprise for you. Entamoeba histolytica is a golden organism. It does not differentiate between AIDS and non-AIDS patients. It attacks both of them equally. There is no extra predilection for AIDS patients. Please take note. Entamoeba histolytica does not attack people in a very faster fashions. Okay. Organism causing this condition. What is your answer, people? All these are repeats with modifications in images. Please tell me. Do not make a mistake in this. No, not Shigella, not Clostridium, Corynebacter, not Campylobacter jejuni. It is Entamoeba histolytica. Okay, what is the answer for this question? Excuse me. Sorry, 1 minute. Yes, what is the answer? Excellent. What you're seeing here is groove sign. So what is the diagnosis? Come on people, what is the diagnosis? Excellent, Ramya. It is lymphogranuloma venereum. What is the causative organism? What is the causative organism? Yes, it is Chlamydia trachomatis L1, L2, L3. These are the strains of Chlamydia trachomatis known for causing this. What is that you're seeing here? This is a positive free test. Let me tell you about freeze test. Listen very carefully. An antigen is made from the sterile pus aspirated from a previously unruptured abscess. That is, you take an unruptured abscess, you aspirate and take the antigen, and that antigen produces a reaction in patients with lymphogranuloma venereum when injected intradermally. That is called as Frey test. I repeat, in a previously unruptured abscess from any patient, you take the antigen and that antigen is injected into a patient who might be suffering from LGV. If he is suffering from LGV, you have a reaction. That reaction is called as positive Frey test. Is that clear? Okay. No, Nirupam, this is not Calymatobacterium granulomatis. This is not granuloma. See, lymphogranuloma venereum is not the same as granuloma inguinale. Granuloma inguinale is the Donovanosis. Donovanosis will be showing you beefy red ulcer which can be bleeding to touch. That is caused by Calymatobacterium granulomatis. This one is lymphogranuloma venereum. This is a groove sign along the inguinal ligament. Above that you will be having the lymph nodes enlarged. Below that also the lymph nodes will be enlarged. It is how it looks like. This is indication for Chlamydia trachomatis. Yes. Let's go for the next question. Which interleukin is responsible for producing IgE from B cells? A very simple question. See, we won't have enough time to discuss about all interleukins, so please take it as a homework. Read about all interleukins. You can expect at least one question from interleukins or cytokines in your exam, either a part of microbiology and immunology or a part of pathology. So please focus on this. Yes, which one? Yes, Eagle 45788, very good. So the answer here would be interleukin 4, and IgE is coming from the plasma cells, and these plasma cells are present on the lymph nodes draining the site of antigen entry or locally, and IgE antibody production requires T helper type 2 cells. The T helper type 2 cells will activate a B lymphocyte and convert them into a plasma cell, and that will be releasing interleukin 4. Which other interleukin 13 also can be released, and this can be inhibited by T helper 1, which releases interferon gamma. These are quick quirky information. B cells can become plasma cells. Tell me, who can produce antibodies, B cells or plasma cells? Come on people. Good evening 4G gamer. Tell me people, who can produce antibodies? Are it the B cells or the plasma cells? This is where we make mistakes. B cells also can produce antibodies. Plasma cells also can produce antibodies. Mature B cells will produce lesser amount of antibodies, while plasma cells are highly powered cells who can produce massive number of antibodies. So remember, both can produce antibodies. This is what I want you to remember for your exams. Okay. Oh, thank you very much, Sohanar. Now let's go for this one. HBsAg is based on which principle? What is your answer? Identifying HBsAg is based on which principle? Yes, all of you are correct in that. Is that okay if I discuss about the antigens serology of hepatitis B? Only if you want it. If you're already very well versed in it, I won't touch it and make your difference. Tell me, is that okay if I do you want me to teach you this hepatitis serology? Okay, I'll make it fast. Look at this. There is something called as Dane particle. Dane particle is the complete form of extracellular hepatitis B. I'm giving you the most important points only, no stories and nothing. We are just going to hit the area. At the end of this, you will be able to answer everything very well. Extracellular viral particle, the complete form is called as Dane particle. Now, as the Dane particle enters into a host, it splits into core antigen and surface antigen. It divides into core antigen and surface antigen. The surface antigen is referred to as HBS antigen. The core antigen is referred to as HBC antigen. If at all you think about the core and the surface, core is always weaker, but it is intelligent, while surface is stronger but carries no information. In a virus, information means what? It is the nucleic acid. Be it an RNA or a DNA, the nucleic acid is called as intelligence. So the core contains the DNA, that is the genomic part. Remember, HBV, hepatitis B virus, belongs to Hepadna viridae, and Hepadna viridae means Hepa DNA viridae. So it is a DNA virus. Now we are done with this. Now let's look at what is happening inside. When the virus HBV, the HBS antigen is entering into the circulation, it can be stable. Why? Because this is a tough antigen. It won't break so faster. But HBC antigen, the core antigen, instantly breaks. As it breaks, it gets converted into a different antigen called as HBE antigen. Can anybody tell me what is the other name for the HBS antigen? That is another MCQ. Come on, people. What is the other name for? Yes, thank you very much. Thank you, Ramya. Can you tell me the other name for the hepatitis B-S antigen, surface antigen? Excellent, Parashuram. This is called as Australia antigen. We don't call it as Australian, it is Australia antigen, and this HBS antigen will be found in the circulation. So whenever the infection happens, if you draw blood for serology, remember the HBC instantly breaks, so it is not available. So what are the points you have to remember? HBC antigen never seen in serological investigations. So what is the first antigen to be noticed? The first antigen to be seen is HBS antigen, because the HBC antigen will take time to break. As it is, it initially breaks, it starts breaking, but to completely break to become another antigen is called as HBE antigen, takes time. So if at all you go for a timeline, HBS antigen is the first antigen we discovered. The second antigen we discovered would be HBE antigen in the circulation. Now, what is the rule, thumb rule in case of hepatitis serology? Please remember this for the rest of your life, not just for this exam, but for always. Remember, an antibody for any hepatitis B antigen appears only when the corresponding antigen disappears. Generally, we do not teach the same way in case of bacteriology or other kind of viruses. Only as long as the antigen is there in the blood, the antibody is formed. As long as the virus or the bacteria or the pathogen is present in the blood, the antibody will be synthesized. But in case of hepatitis serology, for an antibody for a particular antigen to appear in the circulation, that antigen should first disappear. So let me look at this once again. Tell me which antigen first disappeared. Tell me which antigen first disappeared. Come on, people, which antigen disappeared? First antigen to disappear would be excellent, HBC antigen. It means instantly the antibody will be formed. So the first antibody to appear will be IgM anti HBC antibody. I repeat, IgM anticore antibody is the first antibody to appear in the serological process. When they ask you what is the first antigen to appear, the answer would be HBsAg. The first antibody to appear would be IgM anticore antibody. If the same thing is happening, as it turns into chronic, after a while of month, it becomes IgG anticore antibody. Now, whenever HBC antigen is disappearing, it is becoming HBe antigen. When HBC antigen is breaking, it means it is allowing for replication. Now, what does HBe antigen indicate? HBe antigen, if you find them in the circulation, it indicates high infectivity and replicability of the virus. Is that clear? High infectivity and replicability can be noticed. So I hope you'll be able to answer this one. So when they ask you, if a patient is actually having HBs antigen plus IgG anticore antibody plus HBe antigen, what does this indicate? This is how you're going to solve your questions. HBs antigen means there is a live infection present. Please don't commit to call it as either acute or chronic. You will not be able to say whether it is acute or chronic based on HBs. HBs just indicates live infection happening. That infection might have happened only yesterday, or it might have happened 10 years back. But still the viral particle is present. That is what you can say with the help of HBsAg. But acute or chronic will be based on IgG or IgM. So right now you understand there is a live infection happening, there is a chronic infection happening. HBe antigen, if it is present, then highly infective current HBV infection is going on. Now if it is HBs antigen plus IgM anticore plus IgM anti-HBe, what do you think is the logic here? Tell me, what do you understand from this? Latent hepatitis means the virus particle is not at all multiplying and it is not showing any kind of signs or symptoms of serology, because of which patient can't do. The doctors will not be able to see anything. The most common thing is it can be a window period. Come on people, what do you understand from this? See, HBsAg is present, IgM anticore is present, IgM anti-HBe is present. It's a very rare combination, but can you tell me what is your understanding from this? It is acute infection. Okay. Azar, you made a small mistake. Excellent. It is an acute infection with low infectivity. What does this mean? When will anti-HBe antibody come? When will anti-HBe antibody comes? Excellent, Karan Sandhu. Facing out is happening. When will the anti-HBe antibody come? When the antigen has disappeared. What is the rule I told you? Look at this part here. An antibody for any hepatitis B antigen appears only when the corresponding antigen disappears. I'm sorry, I wrote disease. Disappears. So here, when I see IgM anti-HBe, it means HBe antigen is not there. When HBe antigen is not there, it is lowly infective. Is that clear? Yes, you can speak about procure-mutant also. So yes, it can be a okay. Nosocomial infection occurs within how many hours of hospital infection, of hospital stay? What is your answer? I think they have covered a lot of logic. So let's go for more questions faster. Come on people. Yes, Viraj, decrease replication. Very good. What is the answer for this question? Very good, Jeeves. 40 hours of admission and 72 hours of discharge. This is what I was about to say, but Jeeves has given us the answer. Very good, people. Yes, all of you are correct. It is 48. Now look at this part. Now, hospital-acquired infection is also known as nosocomial infection if it is acquired in the hospital or other healthcare facilities. Now, let us look at the most common nosocomial infection. Remember, when they speak about ventilator-associated pneumonia, the most common things will be Klebsiella plus Pseudomonas. Pseudomonas and Klebsiella are known to be causing ventilator-associated pneumonia. When you speak about ICU infections, the most common organisms can be Staphylococcus aureus, Epidermidis, and the other saprophytic staphylococci. You can also have Pseudomonas, you can also have Klebsiella, but never forget E. coli, the most common cause of sepsis, and then you can also have Enterococcus. Is it clear? Now, what are the other things you have to know when you come? See, especially in the ICU, if the patient is on ventilator, then think of Pseudomonas and Klebsiella. Apart from that, you can also expect Clostridium difficile. Do you know what is the recent drug for Clostridium difficile infections? Just do it as a homework, take it as a homework, take 2 or 3 minutes of time. See, hepatitis A and E are not known for causing latent hepatitis. While B and C can be persistent in your body for a longer time, they have a higher chance of causing latent hepatitis. Okay, you cannot have a single answer for this. Yes. Excellent, Azad. That is the right answer. No, oral vancomycin has been in vogue for a lot of years. Initially, they thought metronidazole is the drug of choice for pseudomembranous colitis. Metronidazole is the drug of choice for C. difficile-induced pseudomembranous colitis. Then metronidazole is also capable of causing pseudomembranous colitis. For that, drug of choice would be vancomycin. Now you have to know it is fidaxomicin. Yes, very good. Now let's go for the next question. Which of the following components produced by Neisseria gonorrhoeae is responsible for attachment to host cells? Excellent, all of you. Now when they ask you about who are the other kinds of, yes, all these are real-time questions, so you cannot actually skip on them. See, lipo-oligosaccharide contributes to the endotoxin that is known for causing sepsis. Outer membrane porin protein deals with drug resistance and water transport, while IgA protease helps in stay on mucosa. Why? Because the human mucosal membrane, including GIT, GUT, genitourinary tract, gastrointestinal tract, genitourinary tract, respiratory tract, and ocular epithelia. In all these areas, when the columnar epithelium are present along with mucosa, you have IgA antibodies who act as the policemen of mucosal epithelium. So Neisseria gonococcus, if it wants to stay happily in that local area, it has to bring a weapon called as IgA protease that will break the IgA antibodies and make it more attachable. But to bind strongly, you require an anchor. Why? Because when it is causing urethritis, when it is actually coming through the urethra, it has to climb up the urethra. But urethra will be showing continuous flow of urine. The urine can flush out the bacteria. To stand against the flushing out effect of urine, you require an anchor protein called as P1 pilus. So remember, urethritis can also be caused by gonorrhea. Okay, where will you put chemical, liquid, biochemical, biomedical waste? Answer, people. No, this is not anginal pain, don't worry about it. This is intestinal spasmodic contraction that happens whenever the ulcers are responding. Whenever you have smooth muscles in the local area, the smooth muscles of any area, including your bronchi, uterus, urethra, or your GIT, when there is any painful stimulus that hits you for a minute, it actually goes for spasmodic contraction. That's all, nothing to worry about. I don't have angina. Where will you put chemical, liquid, biomedical waste? Excellent, the answer would be yellow. Remember, chemical waste is categorized into yellow category. The hazardous chemical and cytotoxic waste is a yellow category with a special sign of cytotoxic waste, and it is liquid guidelines. The vaccine to be given after disaster. What is your answer? This is a combination of epidemiology plus that of infection. Come on, what is your answer? Whenever there is a disaster, for example, if there is an earthquake, and the building has fallen and the local soil has been fluffed up, then you will be having spores of the soil entering into the human being. At the same time, any kind of debris, if it is a metallic debris that pierces through your skin, it can carry the spores into your body, and the spores on the surface of the soil will be clostridial spores and bacillary spores. The clostridium spores, if they are introduced into the body, it can easily cause tetanus. So vaccination against tetanus can be given after a disaster, just like after you give it in case of road traffic accident or when there is a nail which is penetrating through your body. Cholera is not supposed to be given after a disaster unless it is coastal area tsunami. Typhoid is not taken into consideration. Tetanus is the answer here. Okay, look at this later. Extended sickness benefit for tuberculosis under ESI Act is, what is the answer? Excellent, Deepak Singh. For the healthcare workers, you have to go for typhoid, cholera and tetanus. What is the answer here? Extended sickness benefit in case of tuberculosis under ESI Act. This is a very routine question. Yeah, the answer would be 2 years. Extended sickness benefit. In addition to 91 days of sickness benefit, insured persons suffering from certain long-term disease are entitled to extended sickness benefit for a maximum period of 2 years. So, in continuous employment of 2 years in tuberculosis. Excellent. Next question. A person reports 4 hours after having a clean wound without laceration. He had taken TT 10 years back. The next step in management is what? Excellent. See, this question is incomplete. The real-time question was also, there were variants of this question. They said, yes, there was a variant of a question. No, not A. If at all they say, the variant of the question is, a person is completely immunized, and it means that is how he has taken 10 years before the same TT. At that point of time, what you need is a single dose of tetanus toxoid. Tetanus toxoid is an active form of immunization or passive form of immunization, people? Tetanus toxoid is active or passive? Quick answer. Remember, toxoids are vaccinations. All vaccinations are active immunization. Now, when they say TIG or any kind of hyperimmune serum, passively offering antibodies directly is called as passive immunization. When you give TT, you are inducing antibody formation. So, your CMI will be triggered to activate HMI to produce antibodies. Antigen presenting cells will come into action. Okay. Recent influenza pandemic was due to? Yes, what is your answer? I understand there is a very good temptation to choose H5N1, but that is not the answer. Remember, the answer would be H1N1. Okay, H1N1. Can you tell me what does H1N1 cause? I am very closely related to H1N1 because I suffered from the disease caused by H1N1. Yes, I suffered from swine flu. Swine flu is supposed to be a pig flu, but generally pigs are not much commonly affected in truth. It will be coming from poultry also. It can come from human beings also. And when I got swine flu, I still remember I was isolated in a room in my house and my mother was having a very genuine question. She asked me, swine flu is supposed to be a pig flu, right? Are you a pig? That is what she asked me. And I still remember the kind of questions that have been raised. H1N1 swine flu causes major flu pandemic in 1918 and 2009, while H5N1 avian influenza is causing only sporadic outbreaks or epidemics. It can cause high mortality. Okay, Mission Indradhanush is for, what is your answer? So neon color marker had, yes, neon color marker had, you had bad flu or Nipah virus. Yes, it's a very simple question. It is universal immunization. We'll discuss about this mission Indradhanush if you want later. Tuberculous otitis media is characterized by all except what is the one that is not found here in tuberculous otitis media? This is ENT with infections. Come on, people. We saw epidemiology with infections. This is ENT with infections. Come on. Which one is not found in tuberculous otitis media? Excellent. See, pale granulations are a must to know in case of tuberculosis because tuberculosis is a granulomatous disease. At least in case of Boeck's sarcoidosis, you will be having non-caseating granulomatosis. But here it is caseating granuloma. You can never say no to it. And foul-smelling ear discharge can be present along with that of additional pyogenic bacterial infections. Additional anaerobic infections can be found in case of ear. And multiple perforations are the ones to notice in case of tuberculous otitis media, but painful otorrhea is not a point at all because there is not much of pain in case of tuberculosis. So the right answer would be A. Painful otorrhea is not found in case of tuberculous otitis media. And remember, patient with active tubercle infection elsewhere followed by a multiple tympanic membrane perforation, abundant granulation, bone necrosis, preauricular lymph node enlargement is all possible, and you can have matting of the preauricular lymph nodes also. Next, the characteristic finding of fungal ulcers is what? Yes, nice. You all are actually giving wonderful answers. Thank you very much. The characteristic findings of fungal ulcers is what? Excellent. The answer would be satellite lesions. See, if it is fungal keratitis, you can have satellite lesions, which is multiple pathologic fungi capable of invading the ocular surface. And remember one thing, fungi will not directly invade. They won't directly invade. If, for example, you're playing with your mother or you're playing with your siblings and they throw some kind of vegetables, the vegetable, imagine the carrot. The carrot in a corner at the end will be slightly greenish. It is because it always carries some kind of fungi. When you hit a human being with the carrot and that touches your cornea, the cornea has been penetrated, the fungus has been already registered and deposited here. The fungal infection that are capable of causing corneal ulcers can be aspergillus and fusarium. Most common fungi known for causing corneal ulcers to cause keratitis. Multifocal stromal infiltrates. Please mark my words. The most important keyword is you can have multiple foci of the infiltration and it can be in the stromal area. That's all. Okay, this is just for an added information. Can you answer this? Yes, vegetable injury is the most common cause of fungal keratitis and the most common fungi would be aspergillus and fusarium. Tell me what is the answer for this question. I wanted to add this because of some other infection. Can you please tell me what is the answer for this? Yes, it is metabolic acidosis. It's already given there. Anything else? See, I'll give you one simple logic. Listen very carefully. Generally, in case of sepsis, what kind of acid-base imbalance do you expect? Because it's a very lengthy question paper and this is going to be a 3.5 hour session and there are 200 MCQs. We may get short questions or we may get long questions also. That 2020 NEET exam was a revelation. It was completely integrated. People were able to link different subjects into one question. So one question did not have a simple logic. It had to have a lot of logic. Yes, when there is sepsis, you expect acid-base imbalance as metabolic acidosis. Do you know the reason? Let me give you quick information. When there is septicemia, if it is going towards sepsis, definitely you understand you can have septic shock. When there is a septic shock, there is decreased perfusion pressure to the tissues. When the perfusion pressure to the tissues are decreasing, then the PO2 inside the cells will fall. When the PO2 is falling, the cells will actually shift towards anaerobic glycolysis. At the end of anaerobic glycolysis, what you expect is lactic acid. When lactic acid accumulates, it is high anion gap metabolic acidosis. Now, this is known to everyone. Let me tell you one extra information. When they ask you what kind of acid-base imbalance can you expect in case of staph aureus septicemia, remember this golden rule. Staphylococcus aureus septicemia on the other side can easily cause metabolic acidosis like any other bacteria, but Staphylococcus aureus is also urease positive. If it is urease positive, it breaks urea into ammonia and carbon dioxide. Now this ammonia, if the urease positivity level of Staphylococcus aureus is continuously high, and if at all the ammonia levels are beating the lactic acid levels, then the patient can have a combinatory metabolic alkalosis. Why am I teaching this? Because some students can be confused. If they say highly virulent urease positive Staphylococcus aureus, then consider the answer metabolic alkalosis also. Are you following this part? Please consider metabolic alkalosis also. Now, what are the previous questions raised from this question? They ask you the organisms who are urease positive, and they asked you to arrange them in an order of descending levels of urease production. People thought urea plasma will have a higher concentration. People thought protease will have a higher concentration. But for per gram tissue of a bacteria which is capable of actually causing urease, H. pylori has the highest density of causing urease, followed by, then you have protease, then you have urea plasma, then you have Staphylococcus aureus, and the recently discovered concept is Corynebacterium urea lyticum. This was an MCQ. Also one more MCQ, Corynebacterium urea lyticum is known for causing alkaline encrusting cystitis, the urinary bladder situation. Is it okay? Yes. Are you all happy with what you're learning? I just want a reaffirmation that I am being helpful. Sometimes when a teacher is very enthusiastic, students may not be benefiting much. I do not want that to happen in this session, because I understand these are the last few days before the exam. Is the session offering you more information than you wanted? Are you all happy? Okay, so in this question, let's look at the answer of this question. See, let me give you a simple answer here. Yes, thank you very much. Yes, now let me erase this. What are the things to notice and how do you understand the answer of this question? See, you have diagnosed it as acidosis. This acidosis can be either metabolic or it can be respiratory. If it is respiratory, PCO2 is the parameter which should have been elevated. If it is metabolic, then bicarbonate is the parameter which should have fallen. This is the simplest logic that you have to look for. Now here you understand bicarbonate has fallen. If bicarbonate has fallen, what is the normal? It is 22 to 28, approximately 24. It has fallen. PCO2 is also slightly fallen, but not massively fallen. So primarily it is metabolic acidosis, and your body is trying to compensate by decreasing your PCO2 also. What is a golden rule in case of acid-base balance? What is the golden rule of acid-base imbalance? When you have an acid-base imbalance, the primary disturbance should be first identified. Either whether the bicarbonate is increasing or decreasing. PCO2 is whether increasing or decreasing. One of the four situations can cause the primary disturbance. Now you have to remember the secondary disturbance will be in the same direction. Will be in the same direction as the primary disturbance. This is what will actually push you through in your life. I'm telling you, remember this rule for the rest of your lives. Now explain this. Primary disturbance can be either bicarbonate rise or fall, or it can be PCO2 rise or fall. If bicarbonate is increasing, it is metabolic alkalosis. If it is decreasing, metabolic acidosis. If PCO2 is increasing, respiratory acidosis. If it is falling, respiratory alkalosis. This is primary disturbance. What is secondary compensation? The secondary disturbance or compensation, the direction of the compensation will be in the same direction as the primary disturbance. Now if I say for example respiratory alkalosis, the parameter is PCO2. PCO2 should fall for causing alkalosis. Now which parameter will be using for compensation? It has to be bicarbonate. So bicarbonate also has to fall. Did you understand this? Yeah, Wintergren's formula. But did you understand this logic, people? Thank you, Daya. I'm happy that you're happy. Yes, did you understand this logic? So now come back to this question here. In this question, if I erase the annotations, look at this. When you understand who has primarily fallen, bicarbonate has fallen. So PCO2 is trying to fall. So this is primarily a metabolic acidosis. Compensation can be respiratory alkalosis. One more thing, the compensation can be anything, but it can never overshoot the primary disturbance. pH cannot actually overshoot to the other side. What does it mean? Look at this part. If, for example, in a particular area, 7.35 to 7.45, this is called as the normal range. If the patient is living at 7.2, that is HCO3 has fallen and PCO2 is trying to fall to push the pH value towards this direction. So no matter how the secondary compensation happens, it has to be within this range. It will not be able to cross over to the alkalotic side. Or you follow this part. It will never overshoot the compensation cannot overshoot. Yes, the correction cannot be more than normal. Now in this question, it is metabolic acidosis. So bicarbonate excess loss by kidney can be an answer. What else can be the answer? Can anybody think of it? What else can be the answer here? The primary disturbance is bicarbonate loss. So bicarbonate loss by kidney is the best answer. What else can be correct? Remember, when your body is trying to push potassium outside, it happens through a potassium proton antiporter. H plus will be taken inside. So because of which K plus excretion can lead to H plus reabsorption. That also can lead to metabolic acidosis. No, Vijayaraj and Silpa, you are saying B, right? B is carbon dioxide expiration by the lungs. Then if carbon dioxide expiration is the lung is the reason for the situation, if carbon dioxide is expired more, you will be having alkalosis and you will be having respiratory alkalosis, not this situation. Is that clear? If H plus excretion by the kidney was more, you will be having metabolic alkalosis. Have I answered? Have I explained it to you clearly? Have I explained it to clearly, people? Okay, let's move forward. Fluoroquinolones with maximum bioavailability is? Yes, fluoroquinolones with maximum bioavailability is? What is the answer? Thank you all of you. Which one has the maximum bioavailability? Yes, the answer is levofloxacin. Levofloxacin's pharmacokinetics are excellent. It can give you 100% bioavailability. But who can interfere with that? You can have multivalent cations like tetracycline can actually interfere with the absorption. Okay, which statement best describes the mechanism of action of azoles? We are coming back to repeats. We have learned one logic very clearly in the past itself. So whenever any question, see, in the first 1.5 hours, we have spent a lot of time on concepts and I have discussed a lot of surrounding information also. Now you can actually use that information to answer further questions also, because in the last 3 years and 4 years of question papers that I'm using here, most of them can be repeats from the previous years. So this is what is our ultimate SUP on USP. You are going with this information forward to your exam. Tell me, what is the answer here? So azoles, synthesis of ergosterol, specifically lanosterol does not become ergosterol, accumulation of a toxic sterol. Okay, targeting beta-1,3 glucan. What is the answer? If there is a targeting of beta-1,3 glucan, what is the antifungal? If you are targeting, excellent, this is echinocandins, fungens. Okay, very good. It can be the same for disruption of cell wall also. Now let's look. Okay, now answer this question, a simple question. 1 minute. And what are the extra things that you have to know from this topic? When they see beta D 1 to 3 glucan assay, and let me tell you some important information here. Some people are confused in case of biochemistry. They'll tell me, sir, what is the difference between glucan and glycan? Remember, if you have an aldose sugar in continuous chains, that is either glucose, 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 etc., or glucose, galactose, mannose, all these are aldose sugar. The chain of aldose sugars is called as glucan, and the chain of ketose sugars is called as fructans. What is a glycan? Glycan is acidified form of a sugar. Acidified form of sugar can be either if you attack the first carbon of that to form an aldonic acid, or you attack the last carbon to cause a uronic acid, or you attack both the carbons and oxidize them to cause, you can have saccharic acid. If an acid form of sugar is into consideration, you have glycan. That is why in glycose aminoglycan, one of them will be N-acetylated sugar, and you may have uronic acid in the form of either gluc-uronic acid or id-uronic acid. Now name that glycosaminoglycan who doesn't contain a uronic acid. Take it as a homework, okay? Yes. What is this? What is the answer to this question? Imipenem, antibiotic with a broad antibacterial spectrum, is co-administered with cilastatin. Which of the following is the best reason for the same? Is it synergism? Excellent. No. It is option D. Cilastatin can be easily broken down by the kidney enzyme. Does anybody know what is the name of the kidney enzyme? See, cilastatin can be broken down by the kidney enzyme. I'm so sorry. Imipenem can be broken down by the kidney enzyme, because of which no matter how concentrated imipenem you give, the imipenem will not be reaching effective concentrations because of the kidney enzyme. So cilastatin will inhibit the kidney enzyme, because of which imipenem's concentration can be maintained in the circulation. Do you know? Excellent. It is dehydropeptidase. Very good. Okay. Now, and when will you be giving this combination? You will give it for Pseudomonas aeruginosa, enterococcal and listeria infection when they combine with that of gentamicin. But imipenem cilastatin can be very effective in most of the infections. DOC for cyclosporiasis, what is your answer? Remember, for cyclospora, you can always go for sulfa drugs. If it is cryptosporidium, can you tell me what is the drug? Sulfa drugs is trimethoprim plus sulfamethoxazole called as cotrimoxazole. Tell me, what is the drug in case of cryptosporidium? In cryptosporidium, it is nitazoxanide. It's not amide, it is anide. Okay, very good, Aishwarya, Nisha and Nikunj Agarwal. Okay, let's move forward. Mechanism of action of oseltamivir. Further questions can be run faster. Come on people, we'll do. We have got a lot of questions. Shall we finish all the 200 questions? Are you in for the game? See, if at any point of time you're feeling bored, or if you're feeling like it is too much of information or it is not interesting enough, you can let me know. We can stop the class. My whole intention was to run a marathon and to try to cover as much as possible. Now it has been almost 2 hours since we started and it is going on. If you feel like we can go for it, if you can go for it, we can go for it. We can go the whole distance if you are in game. Yes, you are trying to inhibit the viral progeny, but the problem is, the mechanism is, it's a neuraminidase inhibitor. It is a neuraminidase inhibitor. Remember, in case of orthomyxoviridae, which is influenza virus, you have a hemagglutinin antigen called as H. You have a neuraminidase antigen called as N. Now H can have variations like 1, 2, 3, 4, 5. N can also have variations from 1 to 9. Now if I say H5N1, it means a combination of this and this. Now in that, neuraminidase has one simple function. Neuraminidase reverses heme agglutination. What is the reversal of hemagglutination referred to as? It's referred to as elution. And that neuraminidase can be inhibited, because of which oseltamivir will be able to control the organism. Remember, what is a neuraminidase inhibitor? Neuraminidase can break neuraminic acid. These are called as sialic acid analogs. Now, the neuraminidase is supposed to act on neuraminic acid or sialic acid, but you give synthetic analogs of sialic acid, because of which if I have a sialic acid here and there is sialic acid alternative here, the alternatives will surround the sialic acid in such a way the enzyme is competitively inhibited, and this is a reversible inhibition, and it causes clumping of newly released influenza virions to each other. Remember, it is not about blocking the release. Whatever the virions are coming to come, you are causing clumping of newly released virions. This is the ultimate mechanism. Okay, remember this for your exams. Neuraminidase is supposed to act on sialic acid, but you are giving oseltamivir, which is actually a sialic acid analog. That sialic acid analog will be blocking the neuraminidase, so that neuraminic acid will be present. So the N is actually, the neuraminidase is not able to function very well, so clumping happens, hemagglutination is not reversed. Are you following this part? So I repeat, thank you very much, Neelam Bardwaj. So I'm saying, when you have hemagglutination, you have to reverse the hemagglutination, and that elution is required for the viral particles to be spread, but that elution is blocked. Did you understand the mechanism clearly, people? Did you understand the mechanism clearly, people? I'm saying, when the virus is supposed to release the virions will actually be, the clumping should be knocked off by the elution principle of neuraminidase. When you block the neuraminidase, continuous clumping happens, though the virions are not released clearly. Okay? Yes. Now look at this part. DOC of diphtheria carrier status, the answer is erythromycin. If it is not done, especially if the patient is actually penicillin allergy, then you can go for erythromycin. Generally, erythromycin is not used much in many of the infections. It can be used in Bordetella, it can be used in Corynebacterium diphtheria. Two major conditions where still people are using erythromycin, but because of the advent of azithromycin and clarithromycin, people are not going back to roxithromycin or erythromycin. Okay, let's go for the next question. And when they ask you, benzathine penicillin should be given at 600,000 units for persons who are younger than 6 years and 12 lakh units for those 6 years old and elder. And oral erythromycin should be given at 40 mg per kg per day for children and 1 gram per day for adults. Okay, antiretroviral therapy is to be given. This is a controversial question. What do you think is the answer? Because newer guidelines have slightly changed, but still, if at all they have asked such a question, antiretroviral therapy is to be given in HIV infected patients irrespective of presence of symptoms of CD4 count is less than. Please assume this as a straightforward question. Among the four, which one should you choose? What is your answer? Okay, there are many kinds of answers here. The right answer is 200. Please take note of this. It should be approximately 200. Yes, irrespective of CD4 counts, you have to start. Correct. That is the new guideline. That is a wonderful information given by Azhar and Dr. Shi. Currently, the new guidelines is irrespective of the CD4 counts. Irrespective of CD4 counts, you have to go for the antiretroviral therapy if the symptoms have started. But this question, I suppose, is from 2017 and repeated in 2018. So if this is the question, and if such a question comes back again in your exam, I would suggest you to go for 200. Okay, consider ART. Okay, 1 second. Okay, look at this question here. All these questions have been given to me by students and they had asked me in the past. I have collected all these questions from the past and I cannot say any of the questions belong to me. I have just only modified a few questions. In most of the questions I have used the same, and I thank all those students who have ever given me these questions so that you will be able to be benefited. Okay, and to compile this, it has taken almost what 2.5 days to compile the 100 questions. Slow. Yes, very good. What is your answer? See, even in case you don't like I teaching you this or my session, it's completely okay, but make sure that you go to the session to have these questions. These questions can be helpful for your exams because there's a collection of questions from students. So I thank all the students who have ever offered me things, and the internet. From the internet we have collected a lot of questions because no question exactly belongs to anyone. So whoever has posted such questions or offered me questions, I thank all of you very heartfeltly. Thank you for this. Okay, so now look at this. Abdominal pain, distension, bloody or mucus filled diarrhea, tenesmus, rectal prolapse. What is tenesmus? Extremely painfully contracted sphincter of the anal canal is called as tenesmus. So stool ova parasites. The moment they said stool ova parasites, you have knocked off Campylobacter, you have knocked off Clostridia, because this is not going to be a bacteria anymore. So it was a stupid part. But if at all they said there was no stool and ova, then the questions options A, B can be in contention. Now they're saying barrel shaped eggs. 100% sure it is Trichuris trichura. And please remember, Trichuris trichura is known for causing infantile rectal prolapse. Can anybody tell me why there is rectal prolapse in Trichuris trichura? Thank you, Dr. Amrita. Thank you, Sanjay Gelot. A small request to all of you who are saying thank you here. After the live session is over, when you have time, if you come back to the session once again, on the comment section, after the live session is over, in the comment section, if you post your comments, even if a single dot, if you post it, the session can be alive and floating for some more time so that other people can also watch it. Can anybody tell me? Yes, Jeeves, of course it is invading the muscle, but the key words are, listen very carefully, you will be able to, the worms can often cause edematous rectum. These are the flow words. Edematous rectum is caused by the infection. And remember, this edema will cause rectum losing internal support. And you will be having the worm heads entering into intestinal lining. This will disrupt both the epithelia and the muscles, because of which the muscles will become weaker. So supporting muscles will become weaker and it automatically causes prolapse of the rectum. Okay. Contact isolation is done for which organism? These are simple questions. Come on, people. Yes, thank you very much. So when the session is over, please put a thumbs up. It's like almost like any other YouTube channel people asking you, right? It might feel like that, but the reason here is this can be good karma. It can reach a lot of students so that more students can be benefited before the exam. Sometimes we may feel like we cannot offer some information to the competition so that the competition can actually win. We'll be scared. Even I was a kind of person at sometimes when I'm extremely competitive, I won't give even a small inch of space to the competitor. But then later I realized, when you actually are very confident with yourself and you allow the competition to succeed, you will be able to have a great life. Let me tell you a small out of the box information. There is a difference between jealousy and competition. People may not know the gross difference. The thin line of difference is both of them want to be the winners. But jealous people are those who want to win at the cost of others. Competition means you want the other person also to win, but you want to win better than him. Imagine this, if you're going in a car, if you're going at a speed of 120 kilometers per hour, suddenly a Bugatti Veyron is crossing at 350 kilometers per hour, generally you'll be like, wow, what a car. So you will feel like, let me buy such a car so that I can beat this. That is called as competition. But instead you start imagining, I am going at 120. This fellow is actually beating me. So let him go and crash on a particular tree. That is called as jealousy. Jealousy puts your competitor down. You want to win by putting some other people down. You want to hit them at their weak spot and then you want to win. But a competitive spirit is where you actually allow the other person to thrive. You want him to win, but you want to beat him when he's the strongest, best. That is when you become competitive. Do you get this point here? That is when you become a winner. See, when students ask me, have I felt jealous of someone? I don't feel jealous. Why? Because if you feel jealous, when will you feel jealous? When you think that you'll never be equal as a match to the other person. But if you are actually a competitive spirit person, you will never actually feel offended by anyone or felt let down by anyone. The right answer for this question is diphtheria. Remember, contact isolation is a must for diphtheria. See, carriers are the people who will be giving 10:1 ratio of spread of an infection from a cases. 10 times carriers will spread the infection compared to that of cases. Bangladesh. Oh, thank you very much. Yes, all of you. Okay, thank you, Arun. Thank you, Jadab Devnath. Okay, let's go forward. Yes, and what are the things you have to know about diphtheria? You will be having a membrane. There is a controversy whether it is a pseudo membrane or a true membrane. Don't worry about it. Just a membrane. If it is black or green or gray, it can be a membrane and it is Corynebacterium diphtheriae. At the same time, remember, laryngopharyngeal diphtheria is more dangerous than oropharyngeal or nasopharyngeal diphtheria. Why? Because in the laryngeal diphtheria, you may have a chance of the membrane blocking the airway. But just because the laryngeal diphtheria is potentially capable of causing a blockage, it does not mean tracheotomy is mandatory. Tracheotomy or tracheostomy is important only when there is a blockage of airway. Okay. Yes, whipworm can cause appendicitis. Okay, what is the answer to this question? A child is suffering from recurrent chronic infection with... Yes, a child is suffering from recurrent chronic infections with encapsulated bacteria. One minute, I'll just zoom this for you. Yes, if there is an infection with encapsulated bacteria, which property of the immunity is failing? Can anybody tell me? Excellent. What is failing? What is failing in immunology? If it's an encapsulated bacteria that is causing a lot of serious infections, it means opsonization is failing. And then ask yourself which one is the best opsonizing helper. The answer would be IgG2. Okay, let's go for the next question. Also, which are the other bacteria? Streptococcus pneumoniae, also called as pneumococcus, Haemophilus influenzae, all can cause similar diseases. Okay, drug of choice for isospora is also cotrimoxazole. Okay, Coxsackie virus A16 causes what? Very good, Sahil Sharma. The IgG4 is for fibrosis, especially retroperitoneal fibrosis. Very good. One extra information, when you have retroperitoneal fibrosis, it is one of the reasons why you can have bilateral ureteral constriction. Bilateral ureteric constriction. It can also be triggered by bacteria. Sometimes it can be by E. coli. This is just an added information for you. Yes. Jalil Akbar, MRSA, you cannot actually go for contact. You will never know who is actually the contact in case of MRSA. See, if it is a diphtheria, I told you carriers is to cases, spreading is 10:1. In case of MRSA, you try to go for hand hygiene rather than completely isolating someone, because diphtheria can be spread through aerosols while MRSA spreads through human touch. Here, the meaning of the contact and touch is different. Contact is somebody who has acquired diphtheria and he may be a carrier. Here I am speaking about contact in terms of touch. MRSA comes through hand and the nostril spread. Is that clear? Sorry. Did I help you understand this, Jalil? I can vouch for it. Your question is valid. Some people can choose MRSA also. That is why I am saying MRSA cannot spread through aerosols as such like diphtheria. So if you ask me, I will choose diphtheria more than MRSA, while there are many people who are choosing MRSA alone. But remember, MRSA is not having a Transmission in the form of aerosols. Okay, let's go forward. Coxsackie A16 virus causes hand, foot, mouth disease. Yellow fever is a very simple question. Yellow fever is caused by yellow fever virus, while Rocky Mountain spotted fever is caused by Rickettsia rickettsii. Remember, if anybody wants to learn about the mnemonics or the stories of how to remember, I'm not very good with that of mnemonics, so I make only stupid stories. Stupid stories are so stupid that you will feel like laughing. And I had a session done, Harrison based session on rickettsia. If you search for my name on Unacademy, that is on YouTube, you can search Unacademy Meenakshi Sundaram. You will be getting a site. At the end of this session, there would be a small link which has a playlist of all my YouTube classes on Unacademy. Harrison based rickettsia session, you can look at all of them. Rickettsii is the one who causes Rocky Mountain spotted fever. Okay, and now let's go for this. Pneumocystis jirovecii, what is the right answer? Jalil Akbar Waza, that is why I told you the meaning of contact is different. Here the contact means the person who has come across the virus or the bacteria. So here the contact isolation means you are trying to isolate the human being who is a contact. Now what you are saying is MRSA is touch based contact. This is a different adjective. Touch is also a type of contact. Do you get my point? You can choose MRSA. You are free to choose MRSA. I am just telling you from my point of view, diphtheria is more than MRSA. You can choose MRSA more than diphtheria. It is absolutely your choice. This is a democratic country, right? Do not worry about anything. I just gave you information that the meaning of contact is different. Here it is the person who has acquired the bacteria. Here it is touch. That is the reason for contact. Okay, what is the answer for this? Okay, now listen very carefully. Some of you are saying C, some of you are saying D. This was altered the question. Some of them are saying a different question altogether. They had asked among the following which one is right, except also they have asked. But let me put this very clearly here. Pneumocystis jirovecii is an organism also called as carini when it is known to attack only mice. If it attacks human beings, it's called as jirovecii. Remember, pneumocystis will cause pneumonia only in immunocompromised patients. But seeing pneumocystis jirovecii can either be just infection, or it can be colonization, or it can be seen as a commensal. So you can see the organism without disturbing both immunocompromised people and immunocompetent people. So seen only in immunocompromised is wrong. But if they say pneumocystis jirovecii pneumonia, then the answer would be seen only in immunocompromised patients. And it is not always related with CMV. It is not always causing nematocele, but diagnosis can be done by sputum microscopy. The right answer is B. Did you understand this, all of you? Did you understand the explanation? Yes. All are true about congenital toxoplasmosis except. Yes, let's go faster. We'll finish more questions. Come on, people. All are true about congenital toxoplasmosis except. Okay. So remember, toxoplasma. Excellent. All of you are giving the right answer. It does not cause conjunctivitis. It is known for causing chorioretinitis. It is known for causing hydrocephalus. It can cause cerebral calcification. Now let me tell you one more information. If at all it is congenital, I can't use the word cerebral calcification directly. But if it is an adult toxoplasmosis or even child toxoplasmosis, remember, if the patient is suffering from HIV that has progressed to AIDS, then if a patient is having multiple cerebral calcifications and you are able to point out that the calcification is because of toxoplasma, then it is guaranteed the patient is severely immunosuppressed or he is having AIDS. Likewise, which other situation can come into picture? If at all a patient is having esophagitis and that esophagitis has proven to be candida, then you can understand the patient is having AIDS or very severe immunosuppression. You're making a diagnosis in the retrospective fashion. See, AIDS patients can have candidal esophagitis, but if you're looking at esophagitis and you can make a biopsy and you can find out it is candida, then it is 100% sure the patient has either severe immunosuppression or AIDS. Likewise, cerebral calcification and it is toxoplasma, then also it can be AIDS and severe immunosuppression. Remember, candida can be found in your stools. It can be found in urine. It can be found in sputum. Still, it is not highly pathological. It can be found in both immunocompetent and immunosuppressed people. But candida causing dissemination, candida causing painful esophagitis, both can speak about AIDS. I hope you'll be able to use this information for your exams. Okay. True about triad in congenital rubella syndrome is? What is the answer? Conjunctivitis, if you want to know, conjunctivitis is caused by, direct conjunctivitis can be caused by Corynebacteria and by Neisseria gonorrhoeae. Why is this important? Even if you learn in ophthalmology, you'll realize that these are the two bacteria who can directly invade intact cornea and conjunctiva. So when it speaks about conjunctivitis on undisturbed cornea and conjunctival epithelium, it can be Neisseria followed by Corynebacterium. Yes, what is the answer here? The true triad about congenital rubella syndrome is, yes, patent ductus arteriosus, cataract and deafness. It means your CVS is involved, your ophthalmology is involved and ENT is involved. This is a triad and I hope you'll be able to use them. Disc diffusion method is also known as what method? Yes, it is sensorineural hearing loss. Very good. Yes, it is Kirby-Boyer disc diffusion method. And this question is a very simple question, but many people who haven't learned that portion of general microbiology might find this difficult. So that is why I always, whenever you come to my classes, I tell students, whenever something is actually offered to you as a phenomenon or a concept or a test, learn the topic or the name completely. For example, Yellex gel precipitation test, because one of the questions asked, Yellex test is a type of precipitation, agglutination or something. In that, if you have learnt it as Yellex gel precipitation test as a name completely, life will be jingalala, it will be very happy. At the same time, you have Ascoli's thermo precipitin test. That is also a precipitation done in case of Bacillus anthracis induced anthrax. Yellex gel precipitation is for testing for the toxins, free toxins available in case of diphtheria patient. Also, you learn about Cassoni's intradermal test. Cassoni's intradermal test is an intradermally injected test, and that is done in case of Echinococcus granulosus or dog tapeworm, hydatid disease. Okay, let's go forward. Rubella virus belongs to which family? Yeah, good point, neon color marker. Neon color marker, the point is, you're saying all of them can cause conjunctivitis. But what I meant here was, in intact cornea and conjunctiva, Corynebacterium and Neisseria will be taking predominance. See, Haemophilus is highly invasive, that is why it is capable of causing meningitis, but only when you have minimum to moderate amount of disturbance of the intactness of the cornea and conjunctiva, they can actually be leading to that. Listeria is having even lesser amount of invasiveness. Rubella virus belongs to Toga viridae. Ruby virus or RUV comes under Toga viridae. Simple information. Toga means the long cloth. For example, if there is a king who is walking, on his shoulders lies a very long curtain-like cloth, right? When he walks, and the cloth can even clean the whole, mop the floor. That cloth is called as toga. It can be the curtain. And it is the pathogenic agent of the disease called as rubella, and it is the cause of congenital rubella syndrome that occurs during the first week of pregnancy. And this is a single-stranded, positively stranded RNA virus. This is known to have icosahedral symmetry. because this is unique. Icosahedral symmetry is a property of DNA viruses, while helical symmetry is a property of RNA viruses in general. Okay. Which of the following infection resembles erythroblastosis? What is your answer? Which of the following resembles erythroblastosis? Good going, people. The answer is CMV. CMV is the one that can look like erythroblastosis fetalis. Erythroblastosis fetalis is an example of RH incompatibility. The mother's antibodies can destroy the fetus. See, this infection with CMV, like in EBV, can cause a type of infectious mononucleosis in adults. This is known to cause fever and fatigue. This CMV is also capable of causing a disease that looks like infectious mononucleosis. At the same time, the erythrocytes turning into a blast tissue. Okay, diagnostic test for neurosyphilis is what? Now this is a tricky question. Some of you can answer this easily, but you have to think twice before you give. Yes, it is non-immune eye drops. Very good, Nirupamnath. Can you name one more non-immune eye drops? Can you name one non-immune eye drops? No, from the previous question, can you name one non-immune eye drops? Yes, it can be parvo. Hydrops fetalis is the other name for what? Can anybody tell me what is the other name for Hydrops fetalis? Okay, I'll give you a clue. It is seen in case of hemoglobinopathies. Excellent, Aishwarya Tamil. It is alpha thalassemia. Okay, now let me tell you why the answer is VDRL. See, VDRL, RPR, both of them are non-specific. I'm giving you the logic so that you won't make mistakes in the similar questions. FTA ABS is specific. It was initially, in the older days, TPHA, first gold standard test was FTA ABS. The next gold standard was TPHA. The current gold standard is TPPA. Trichomonopolyden particulate agglutination. Now remember, FTA-ABS specific tests are done in case of confirmation, while VDRL is done in case of screening and also for prognosis, because once FTA-ABS is positive, it remains positive forever. It remains positive forever. So when you give a drug and you want to treat the patient, if the patient is getting better, you can't go for FTA-ABS because it will still remain positive. But VDRL titer will decrease, telling you that the patient is responding to the treatment. Now you have already made a diagnosis of syphilis. That is why you call it as neurosyphilis. If you want to make a diagnosis of neurosyphilis, you don't have to confirm syphilis. You just have to follow whether the disease is getting worsened. So you go for non-specific tests. Did you understand this, people? Did you understand the explanation? Yes. Yes or no? You do not have to go for confirmatory test because you already know it is neurosyphilis. There is syphilis. You just want to know whether it has progressed to stage 3. So you go for a non-specific test. Now some people can ask a question. Okay, non-specific test. VDRL is also a non-specific test. RPR is also a non-specific test. Then why are you choosing VDRL? RPR is known for accuracy, while VDRL is known for precision. Then why are you going for VDRL? Remember, if your blood sample given for glucose estimation is containing 100 milligrams per deciliter. Now, RPR can give you 100 at some point of time, 95 at some point of time, 105 at some point of time, 93, 107 at some point of time. It is giving accurate results, but not repeatability. But VDRL is showing precision. That is, precision means repeatability. What does this mean? If I perform VDRL, If the original value is 100, I may get 98, 98, 98, 98. Now what can you do? You can add a correction factor of +2 because it is consistently wrong in a very small level, but every value is reliable. So VDRL is more reliable because of precision. That is why I choose VDRL more than RPR. Did you understand this? The investigation for congenital syphilis is IgM, FTA, ABS. 19S capita IgM, FTA, ABS. For those people who want to know why IgM and not IgG, remember, when you take the sample from the fetus, for fetus to confirm congenital syphilis, that is, you got it only from the mother, then you go for IgM. Why? Because if at all the fetus is having Ig, generally Ig will not be there in the fetus, but if the fetus is carrying IgM, you are very clear that IgM does not cross the placenta. So IgM would have come only from the fetus, so IgM is the answer. Flask-shaped ulcers in intestine are caused by? Most sensitive is always a specific. You can go for VDRL. Most specific test is FTA-ABS and TPPA. Yes, flask-shaped ulcers. People thought flask may look like this, but no, it is a round-bottomed flask. This is what I have to tell you. It is Entamoeba histolytica. Let's go faster. What type of culture media is used for Legionella? What is the answer? Kiran SK, that question was discussed 20 minutes back. You can go back to the session. For those people who would want to choose MRSA, please feel free to choose MRSA also. MRSA can also be accepted. Diphtheria is also accepted. So I would choose diphtheria ahead of MRSA. You can choose MRSA ahead of diphtheria, both done. Okay. The right answer for this would be Legionella. It is buffered charcoal yeast extract. Why is this important? Because Legionella generally is not cultured, but if at all you culture, you can have a specific media for it called as BCYE. Now, in case of picture-based questions, if they show you two kind of culture media, where one media is actually black after the growth of organism, when the whole medium is turning black after culture, then it can be your cysteine or potassium blood tellurite agar, which is the most specific test for, the most confirmatory test for Corynebacterium diphtheriae. But if the medium is black even before culture, then it is buffered charcoal yeast extract, because charcoal offers the black color. Did you understand this? Did you understand this? How to identify both? Okay. BCYE is selective for certain gram-negative bacteria, especially Legionella. The organism is nutritionally fastidious. What is fastidious? Fastidious organisms are those who have exacting growth requirements. So it can also be not only a selective media, it is also can be an enriched media. And remember, cysteine, yeast extract, alpha-ketoglutarate, iron are all present for isolation of Legionella. Remember, the amino acid and the keto acid required is alpha-ketoglutarate. Okay, what is the answer here? Yes. Special stain for Cryptococcus. What is the answer? Again, for those who have been very patient with me and those who have watched this session, just help other students also watch the session. At the end of the session, when the class is over and if it goes offline, please comment either A, B, C, D, whatever it is. If you like the class, you can put good comments. Otherwise also it's okay. If you make comments, the video will be floating in the internet for an extra while so that others also can watch it, so that you can help others. And please put a thumbs up so that the video can actually spread to others. Please comment and share so that others can also learn. The answer here is mucicarmin. Remember, mucic acid is an acid plus an amino group is added, and this will have strong attraction towards polysaccharides. Strong attraction towards polysaccharides. Why polysaccharides? Because the polysaccharides are the components of cryptococcal capsule. They are the components of cryptococcal capsule. Cryptococcal capsule is made up of polysaccharides which can have a strong attraction towards mucicarbon. Okay, next. And remember, histoplasma capsulatum is not capsulated. Yes, it can be India ink preparation to wash the capsule under dark field microscopy. Yes, the answer question. 36-year-old male patient complains of cough, cold, fever, rusty sputum, sputum negative for tuberculosis, history of travel to China, and eaten crab. What is the organism? It's a very simple answer. The answer is lung fluke. Let me give you a small tip. When you read about the life cycles of different parasites, when you come to flukes, try to look at the precursor word before the word fluke. When they say lung fluke, when they say liver fluke, when they say gallbladder fluke, when they say intestinal fluke, when they say blood fluke, the simple tip is, in the whole life cycle, you will find the adult fluke worm in that area. This is the clue. Blood fluke, example, Schistosoma hematobium, Schistosoma japonicum, Schistosoma mansoni, where the larvae can be anywhere, but the adult worm will be in the blood vessels, especially the venous plexus. The venous plexus of your urinary tract will be for hematobium. The venous plexus is present around the enteric system would be japonicum and mansoni. In the lung fluke, adult worm will be in the lung. In liver fluke, which is Fasciola hepatica, the adult worm will be found in the liver hepatic lobules. And gallbladder fluke will be your Clonorchis sinensis. And intestinal fluke will be Fasciolopsis busci. In the recently conducted INICT exam, July INICT exam, there was a question about Fasciolopsis busci. When I did my INICT recall, I thought the option given was Fasciola hepatica. So I said it was a right statement to say Fasciola hepatica is present in the liver lobules. But if the option is Fasciolopsis busci, it is not found in the hepatic lobules. Now how do I know this is Paragonimus westermani? Because you are saying rusty sputum. Sputum involves either the upper GIT or your lung. And it can speak about the cough and cold, which is actually native for TB. So I think about lung infection, that is Paragonimus westermani. And why eaten crab? Paragonimus westermani can spread through raw or uncooked seafood. These are the extra data that you have to know for. And can it, excellent Sahil Sharma, causes gallbladder cancer. Can anybody tell me what kind of gallbladder cancer is caused? I mean, not gallbladder, it is urinary bladder. What kind of urinary bladder cancer can be caused by schistosoma? Is it transitional or squamous? Yes, Clonorchis will cause. See, whenever a particular organism is present as a carrier or present in a local area for a longer time, first it causes local histological changes. Then it can cause metaplasia and anaplasia. Then it can become complete neoplasia. All these things are possible. For example, hepatitis B virus initially causes hepatitis. It becomes chronic hepatitis. Then it becomes cirrhosis. Then it becomes hepatocellular carcinoma. Likewise, it is not transitional cell carcinoma. That is why I asked you the question. You know transitional epithelium is lining your urinary bladder, but it causes squamous cell carcinoma. This is the information you have to go with your examination. Okay, microbiological test for diagnosing leptospira infection is what? Yes, it is microscopic agglutination test, MAT. This is gold standard. At the same time, there is one more test called as CAT. Cold agglutination test is for mycoplasma. I'm so sorry for some of you. You might be requiring your dinner. I forgot about my dinner, but I think you will all be hungry. I'm so sorry. We'll finish the class sooner. Okay? Please don't curse me. Yeah, no, it's okay. I'll finish it and go forward. Okay, green color of triage is for which patient? Come on, people. Thank you so very much for your kindness. Yes, what is the answer? The answer is ambulatory. If it is high priority, you go for red. If it is, that is, red is for high priority, medium priority is yellow, ambulatory patients is green, and black will be for dead or moribund patients. Okay, who is a paradoxical carrier? Anybody? Yeah, I can do it as special classes later, but if I don't finish it today, then you'll be having only 3 more days to learn this. That is why I want to do it now, once and for all. You learn some 100 MCQs and you feel comfortable with the microbiology. You can go to the exam without thinking of anything else. That is my only concern, okay? Yes, excellent. Nandi, Nandu, Jyotsna Gupta have all given the right answer. Deepak Singh, very good. A person who acquires the microorganism from another carrier and he becomes a carrier and is not going to suffer from the disease, they are called as paradoxical carriers. Okay. If you acquire from a patient or a carrier and you fall ill, you are a patient. But you acquire it from a carrier and you also become a carrier, you become a paradoxical carrier or reverse carriers. Okay, which is not an epidemiological indicator. Come on, people. Which is not an epidemiological indicator in case of malaria. This is an epidemiology question plus that of microbiology question. So I just wanted to add this to you. The answer would be no, you can't make mistakes in this. The answer would be ABER. What is ABER? Annual blood examination rate. It is blood examination rate. This is not speaking about the infectious load. This speaks about the ability of the government or the ability of the system to perform something. So you can't take it as an indicator. But annual parasite index, annual falciparum incidence speak about the load of the disease. Do you understand the difference here? This speaks about performance of something. Examination rate of the blood. How many blood examination has been done? That is about the performance characteristic. ABR is a performance characteristic, while B and C are the load of the disease. Did you understand this, people? Yes, let's go forward. Dose of diphtheria antitoxin is 10,000 to 100,000. So remember, it is manufactured by Institute of Butantan and is a sterile, transparent, clear serum solution. Remember, the diphtheria antitoxin is a clear solution, not smudged. At the same time, it should be stored in the refrigerator 2 to 8 degrees Celsius. Please remember, do not freeze diphtheria antitoxin. Once you open it, you have to be immediately using it. Vertical transmission of HIV is highest with what? This is a very easy question. The way they have framed the question is also not highly intelligent. Remember, if you have breastfeeding, there is a possibility of transmission. Term delivery, possibility of transmission. Elective cesarean section, lesser and lesser possibility of transmission because you have proper precautions and the child and the mother will be hit with either nevirapine or zidovudine. Okay, nevirapine or zidovudine. This will be very effective in preventing the transmission. But when the child and the mother is having high viral load and is not controlled by the antiviral agents, then that can be the highest chances for transmission. Simple answer. Now, what are the transmission rates? In case of pregnancy, it is 5 to 10%. In labor and delivery, 10 to 15%. Breastfeeding is 5 to 20%. Overall, without breastfeeding is 15 to 25%. Overall, with breastfeeding to 6 months is 20 to 35%. And overall, with breastfeeding to 18 to 24 months is 30 to 45%. Okay. Punched out ulcer in esophagus is seen in. What is the answer? Punched out ulcer in esophagus is seen in. It's a very close call. The answer is generally esophagitis. It can be because of any reason, especially pill. But some people are choosing herpes, right? Herpes will cause dendritic ulcers. Herpes is known for causing dendritic ulcers, and it can also be, yes, serpiginous ulcers. Okay. General cause would be, yes, esophagitis. What is serpiginous? Okay, can you tell me, serpiginous ulcer in the cornea is found where? Serpiginous ulcers in cornea, which infections? This is not always true, but this is always true. Serpiginous ulcers in cornea is found in which infections? Or serpentine. Take note of this. In case of pneumococcal keratitis. In case of pneumococcal keratitis, it is called as serpiginous. It looks like as if a snake has crawled through the area. That is how the ulcers will be. Okay. Most characteristic cardiovascular defect seen in rubella is? Yes, very good all of you. Okay, let me tell you. The most characteristic cardiovascular defect seen in rubella would be pulmonary artery stenosis. Generally, I told you, right, CVS will be involved, eye will be involved, and your ear will be involved. You can have eye, cataract, CVS, you can have pulmonary artery stenosis. In ear, you can have sensorineural hearing loss. And can anybody tell me what kind of cataract you see in rubella? Yes, patent ductus arteriosus is of course sure, but out of the given options, what is the right answer? Yes, pulmonary artery stenosis. Yes, what kind of cataract will you see? Yes, at the core. What else? How do you describe the cataract in case of rubella? No, Timmy Tommy, you are almost 15 minutes late in the video. I think you're running late in the video. It should be squamous cell carcinoma in case of schistosomiasis. Yes, it is nuclear. Okay, go forward. Which is not related to HIV? Among this, which one is not related to HIV at all? See, primary CNS lymphoma is a transformation based infection. There are viruses which are referred to as transforming viruses. When will you call the viruses as transforming viruses? For example, HTLV, HBLV, HPV are all good examples of transforming viruses. Why? Because they are able to transform a normal cell into a malignant cell. So HIV here is capable of introducing lymphoma into the CNS, though it is not exactly a transforming virus. Remember, esophageal candidiasis can happen in HIV bar AIDS, toxoplasma calcification can happen, but tertiary syphilis has nothing to do in case of syphilis, in case of HIV. Let's go forward. Essential major blood criteria for infective endocarditis is what? This is an intelligent question. Come on. Yes? Okay, let me tell you. The answer is a single positive culture of Hasek bacteria. Sorry, I'll erase this, what I have written here. A single positive culture for Hasek. Tell me what is Hasek? It is Haemophilus Afrophilus Aeis aggregati bacterium. Previously, what was the name for it? In the Hasek, the A was referred to as Actinomycetes, Actinomycetem comitans. This was a very huge name. I repeat, Actinomycetes, Actinomycetem comitans. Now it is called as aggregati bacterium. C stands for Cardiobacterium hominis. K stands for Kingella kingae. E stands for Eikenella cordens. What is common to all these organisms? All these organisms are fastidious. If you find a single positive culture, you can make a diagnosis of infective endocarditis here. No problem, don't worry about it. Coxiella you can take into consideration. So because they are giving APC, Coxiella can be taken into consideration, but many people don't accept Coxiella single positive culture as the right answer. Now look at this part. You can have this information here. Most common culture negative organisms can be Coxiella burnetii, Bartonella, Triforima vapilli, and Streptococcus in people who have received antibiotics. Now, Hasek organisms are not a common cause of culture negative infective endocarditis, but still, if you can say a single point, you will be able to accept them. So, some people can say A and B is the answer. Some people say only A is the answer. It is up to the discretion of a cardiologist who would want to go for it. Now, what is common to all the HSEC bacteria? HSEC bacteria are gram-negative. They are commensals in the oropharyngeal area. They are relatively fastidious, and they all love carbon dioxide. And they can cause endocarditis as a long interval between the first symptom and diagnosis. Please remember this for your exams and know the names of the organisms. A is not Actinobacillus anymore. It is aggregative bacterium. Okay. And Ichinella cordens is a very common cause of infection spread through human bites. And what else do you have to know? The most common organism spread through human bites can be Ichinella cordens, followed by Streptococcus. Can you tell me what is the most common infection spread through dog bite? Yes, the most common organism spread through dog bite is not rabies. It is Pasteurella maltosida. Remember, there was a question raised about Pasteurella maltosida. This organism contains capsule, so it can become dangerous in asplenia. What else have you to remember? It can also be capnocytophaga. When a patient is suffering from severe overwhelming sepsis because of a capsulated bacteria, when the dog bite or dog scratches, it can either be Pasteurella or it can be capnocytophaga in case of asplenia. Is that clear? Yes. Let's go for the next question. Serpiginous ulcer distal esophagus. The answer would be CMV. This is a relative question like that. Next, most common joint involved in septic arthritis would be knee, because of the dependency and because of the weight bearing areas and because of the blood supply. Three reasons for the most common area to involve in septic arthritis. And what is the most common cause of pyogenic osteomyelitis? I'm giving you data here. Listen very carefully. For pyogenic osteomyelitis, the most common cause would be Staphylococcus aureus. For non-pyogenic, you cannot actually have much of a discussion on that. It could be MTB. Most common pyogenic osteomyelitis in asplenia would be Salmonella. All these are rapid data. Remember all these things. Most common cause of pyogenic osteomyelitis is Staphylococcus aureus. The most common cause of osteomyelitis is also Staphylococcus aureus. If they mention it as non-pyogenic, you go for MTB. In case of asplenia, you think of Salmonella. Okay. Next, green frothy vaginal discharge is produced by. Yes, what is the answer? Very good, all of you. The answer is Trichomonas vaginalis. What kind of vagina does it cause? It can cause strawberry spots. First line of treatment of mastitis in a lactating mother is dicloxacillin. You are not trying to use ceftriaxone because use of ceftriaxone can induce MRSA. You are using a dicloxacillin plus that of a beta-lactam antibiotic. I mean with a beta-lactamase inhibitor. Dicloxacillin can be the first line of treatment for mastitis in a lactating mother. Which vaccine is contraindicated in pregnancy? Come on people, what is the answer? Are you all tired? Are you all feeling like cursing me? I understand if you are angry with me because of continuing, but in case you would like to continue, there are just 10 more questions, I believe. Shall we finish it off? We have covered almost 90 questions, I believe. Will you be okay if I finish all of them? Yes. Here the vaccine contraindicated in pregnancy would be chickenpox. Why? The reason is it's a live vaccine. What kind of vaccine is hepatitis B? It's a subunit vaccine. Yes, thank you very much. Okay, what are the other live vaccines contraindicated in pregnancy? Measles, mumps, poliomyelitis, rubella, yellow fever, varicella, BCG. Okay, let's go for the next question. Identify the infection from the chest X-ray of a patient with a low-grade fever. Identify the infection from chest X-ray of the patient with low-grade fever. Yes, it is nothing but miliary TB. What is miliary TB? It has shown hematogenous dissemination and can have millet-like lesions in multiple organs. Remember, either it is a primary or a secondary hematogenous dissemination, treatment options will become lesser and lesser. To save the patient becomes difficult. Hematogenous dissemination, like millet-like lesions, can be present in the liver, it can be present in the spleen, it can be present in the chest, in the lung also. Okay. Next, identify the condition. This is the child with asthmatic mother. This is the child. The mother is asthmatic. Let me zoom this for you. Okay, this was the picture raised in the exams, I believe, as close as possible. Yes, it is nothing but atopic dermatitis. Okay, let's go forward. Oh God. Okay. Okay. The causative organism for this condition depicted in the image is what? Can you tell me what you're looking at here? Definitely can't be candidal, and it is not actinomycetes because pus discharge or mystomatous mass is not fair. So you have ruled out D and B. It can be between that of A and C. What is your answer? Excellent. This is a case of impetigo. Remember, impetigo can be of two types. It can be simple impetigo and it can be impetigo contagiosa. Remember, impetigo contagiosa can be identified by honey colored crusting on the edges. Honey colored crusting on the edges. When it is impetigo contagiosa, highly contagious, there is none other than Staphylococcus aureus being the most common organism. The honey colored crustings can be seen around the mouth area. Okay, what is the answer of this question? Multiple perforations you can notice here, here and here. What is the answer? Excellent, very good. This is nothing but tuberculous otitis media. These are very common questions in ENT. And what is the feature that is not found? The clinical feature not found is painful otorrhea. Painful otorrhea is not found, and these are multiple perforations. Okay, we are going faster. A 6-year-old boy is having symptoms such as fever and chills, cough, rapid breathing, difficulty breathing, chest pain. Culture from a sample shows gram-positive culture. What is your answer? Look at this, fever, chills. Then you have rapid breathing, difficulty breathing. This is a case of pneumonia, and chest pain can indicate it can be lobar pneumonia. Assuming if it is lobar pneumonia and the culture shows gram-positive diplococci, then the answer has to be one and only Streptococcus pneumoniae. Okay. What is the picture here? Identify the picture given. This is a case of herpes zoster along a dermatome. It is not atopic dermatitis. Chickenpox will be showing you the lesions of all stages, macules, papules, vesicles and pustules. This is not smallpox because it has not been seen, because smallpox will show hemorrhagic or crusting types. Okay, now look at this. Identify the disease caused by the vector. First you have to identify the vector, then you have to speak about the disease. What is the answer? See, the answer is, yes, very good. The answer is Japanese encephalitis. Can you tell me what is this particular vector mosquito? Yes, this is a case of Culex titaniorhynchus. Now look at this. Culex looks like this. Anopheles looks like this. Look at the abdomen here. And look at Aedes. It is a dark mosquito with multiple bright spots. If you see a dark multiple bright spots, Aedes looks like a tiger, right? So remember, this is Aedes. Let's go for the next one. Site of action of amphotericin B is? Very good. It sits parallel to the surface. Very good. Yes. Shall we go faster with the remaining MCQs? Shall we go slightly faster? Is that okay with you? We'll discuss question and the answer. Okay. See, amphotericin B does not attack your wall, and it is known to attack your, 1 minute. Sorry. Amphotericin B is not concerned about beta D glucan synthesis. It is concerned about attacking your cell ergosterol and causes pores in them. Okay, it is known to attack your pores. Yes, it attacks on the membrane and can cause sequestration. Which antiretroviral drug also has anti-hepatitis activity? What is your answer? Anti-HIV drug having anti-hepatitis activity is, yes, let me tell you, yes, it causes pore formation, ergosterol dysfunction or dismemberment of the amphotericin B. Here, antiretroviral therapy, anti-hepatitis activity is found in case of M-tricitabine. Okay. Nucleoside reverse transcriptase inhibitor for the prevention and treatment of HIV infection in adults and children. It is used generally in combination with that of tenofovir, which is not a bacteriostatic antibiotic. Which is not a bacteriostatic antibiotic in the given answer, in the given answers, which is not bacteriostatic. It means choose a bactericidal agent. The answer for the previous question is M-tricitabine. Okay, it can be both vancomycin and cephalosporin. Amphotericin B, the question is wrong and the explanation given by many people is wrong. See, amphotericin B will prevent ergosterol filled membrane from being integral. It breaks integrity of the ergosterol filled membrane. So it causes dysfunction of the membrane. So it attacks the membrane is what I can choose. Is it okay? Sri Aruna Krishnan, have I answered your question? Sri Aruna Krishnan. Okay, remember cephalosporins, vancomycin can come in the same logic. Who are the bacteriostatic antibiotics? It can be tetracycline, sulfonamides, clindamycin, spectramycin, trimethoprim, chloramphenicol, macrolides and lincosamides. Aminoglycosides are also protein synthesis inhibitors, but they cause premature chain termination and they can cause toxic infections. They can produce toxic protein synthesis. That is why even though they are protein synthesis inhibitors, they are capable of being bactericidal agents. Okay, which among the following will be the choice of antibiotic for a bedridden patient with catheter-related UTI pneumonia? Come on, what is the answer to this question? Okay, so if a patient is having catheter-related UTI pneumonia, the answer can be D. It is beta-lactam antibiotics with the beta-lactamase inhibitor. Okay, Mycoplasma is resistant to. Mycoplasma is resistant to. See, the same question should not contain both. The best answer would be cephalosporin. Why? Because Mycoplasma is not known for cell wall. They are cell wall deficient organisms. So if when you use any drug which is known to attack your cell wall, it won't be able to show much of results. Aminoglycosides and fluoroquinolones can show some kind of activity, but cephalosporins will not show much of an activity. So remember, because I have used the previous year questions in multiple slides, some questions are improperly framed, some questions are not complete, some questions may have mistakes in them. I have tried to address as many mistakes as possible and I have given you my version of the answer. Some answers may not be suitable for you, but this is the best way I could actually give you an answer. You can trust them, or if you feel like you have to go for your answers, you are supposed to do it. Okay. Next, Burkholderia cepacia is resistant to which of the following drugs? This is a simple question. It's a combination of pharmacology with that of, yes, it's pharmacology with microbiology. Come on. Simple answer. Burkholderia cepacia is resistant to first and second generation cephalosporins. So cephalotetan comes under second generation, and third generation and above will be for ceftazidime. It is useful. Cotrimoxazole, temocillin, all can be effective against Burkholderia cepacia. This is the best way by which you can look at it. Cefazolin, cefalexin, first generation. Cefaclar, cefotetan, cefoxetine, cefuroxime, second generation. Cefixime, ceftoxime, ceftazidime, ceftriaxone, third generation. Cefepime, fourth generation. Ceftarolin, fifth generation. And similar to third generation, but it also has, this also has MRSA coverage. When you move from first to the last generation, the gram-negative coverage will increase. Shingles is caused by which of the following? The answer is varicella zoster. If it is herpes simplex, you simply call them as zoster. But if it is varicella zoster, the zoster is referred to as shingles. Remember, if it is varicella part of the virus, it is known for causing chicken pox. The same virus becomes latent and shows the zoster form, then that is called as shingles. Next question. Urea breath test is done for diagnosis of H. pylori. How will you do that? When you have the urea coming out, you expose the urease coming out of the bacteria onto the urea. The urea instantly breaks into carbon dioxide plus ammonia. This carbon dioxide can be taken into consideration. That is what is called as urease breath test or urea breath test for H. pylori. Okay. Hyperacute graft rejection. Hyperacute happens in minutes because the antibodies are already prepared. Australia antigen for hepatitis B is HBs antigen. Which fungus is most commonly related to orbital cellulitis in diabetic ketoacidosis? See, when you mention DKA, you have to think of two organisms. One is mucor, the other one is aspergillus. But if they mention it is A septate with wide angle branching and it is happening only in DKA, the answer can be mucor. If it is septate higher fungi with acute angled branching, think of aspergillus. Candida is not known only for diabetic ketoacidosis. Generally, diabetic people will be more prone for Candida, like AIDS patients. Even rhizopus can lead to the same information. Sabin-Feldman dye test is done in case of toxoplasmosis. This is an antibody-based test. Can you tell me Napier's aldehyde test is done for whom? Napier's aldehyde test is done where? Anybody? Excellent, in case of leishmaniasis. Acute hemorrhagic conjunctivitis is caused by which of the enterovirus type? Very good. The answer is 70. Remember, enterovirus 17 acts as the causative agent. Acute hemorrhagic conjunctivitis is characterized by conjunctival congestion, vascular dilatation, onset of edema. You can have Coxsackie group A24, enterovirus 70. Okay. Echinococcus granulosus is commonly seen in which of the following animals? It is dog. It is dog, tapeworm, while dog is the definitive host, man is the intermediate dead end host. Remember, for the previous question, there is an opinion that 70, 71 both can be involved. So this is a gray area. You can choose whichever from the textbook that has been given. Okay. An anaerobe causing anaerobe multiple abscess with discharging sinuses demonstrating sulfur granules in pus. See, this picture has been very common. I forgot to add the picture here. They will be showing an African person. Every common picture in the AIMS exams and the NEET exams have been an African male. He'll be having a jaw from which it will be pouring out. You will be calling that as actinomycetes. How do I say it is actinomycetes? Because it is anaerobic. If they had mentioned it as aerobic, then the answer shifts towards nocardia. And why is it bacterial mycetoma? Because there are sulfur granules. If they are black discharge, it becomes eumycetoma caused only by true fungi. True fungi, you will be having black discharge. Sulfur granules means it is bacterial, and if it is anaerobic, it has to be actinomycetes, and you can call them as cervical actinomycosis, thoracic actinomycosis, and it can also be abdominal actinomycosis. Three variations of your body parts. Okay. Next, which organism causes acute bacterial prostatitis? The answer should be E. coli. Acute bacterial prostatitis is E. coli, and it accounts for 10 to 30% of the cases. Enterococcus can also cause it. Klebsiella proteus can also cause it. But if it comes to E. coli, it is 50 to 80% cases. I repeat, if there is enterobacteriaceae like Klebsiella and proteus, 10 to 30%, but E. coli can lead to 50 to 80% of the cases. Which of the following organism releases histamine and causes cromboid fish poisoning? This is a very famous question in the last 2 years. In the last 2 years, listen carefully. In case of E. coli, in case of Pseudomonas, you will be having a chance of releasing a lot of histamine, and scromboid fish is known for releasing this, especially. Look at this. It is one of the most common cause of morbidity associated with fish intake, and if it is not refrigerated properly. What happens? Whenever you are refrigerated, if you are actually storing the fish for a longer time without proper preservation, it induces enzyme release. Those enzymes can come from Morganella, Escherichia, Klebsiella and Pseudomonas, and that can be coming from fish cutis and intestines. When they release that, then it can lead to scromboid poisoning. Who is the father of microbiology? There is a very common argument happening every time. Remember, the first person who worked with the microscope was Anton von Leeuwenhoek. It is H-O-O-K-E. And it is not Robert Brown. If at all you want a competition, it should be Robert Koch. Robert Koch is called as the father of bacteriology, and Louis Pasteur would be the father of modern microbiology. Some people call Louis Pasteur as also the father of bacteriology, but this is a very common opinion. Robert Koch will be the father of bacteriology, Pasteur modern microbiology, father of original microbiology would be Anton von Leeuwenhoek. Okay, I'm so sorry, what happened, I don't remember. Okay, cutaneous larva migrans is caused by which organism? Anybody? Cutaneous larva migrans is caused by which organism? Yes, it is Ankylostoma brasiliensis. Remember, if it is Ankylostoma duodenale or Necator americanus, these two organisms are known to attack human beings for a very long time. They are proper hookworms. They know where to go in your body. But Ankylostoma brasiliensis are not meant for humans. So when they come into the humans with the help of the filariform larva penetrating, they lose their way. They get lost inside the human body. They crawl through the skin. So Ankylostoma brasiliensis is known for causing cutaneous larva migrans very commonly. It is also referred to as wandering larvae in the skin, also referred to as plumber's itch, also known as ground itch. Okay. After kidney transplantation, which organism infection is more likely to happen? The answer is CMV. And it can be happening in transplantation. The patient can show fever, leukopenia, heberosplenomegaly, myalgia, arthralgia. Just 5 more minutes, we'll finish the session. Okay. What is the mass chemoprophylaxis for meningococcal meningitis? Remember, right now when they ask you what is the chemoprophylaxis for meningococcal meningitis, the answer would be cephalosporins. But previously, if you are going for mass chemoprophylaxis, then rifampicin can be an answer of choice. Okay. Kala Azar is found as an endemic in areas except. Endemic means what? Localized to one particular area. See, West Bengal, UP, Bihar, Jharkhand are very common to be endemics for Kala Azar. Assam is not an endemic area for Kala Azar. Assam is not an endemic area for Kala Azar. Okay, pasteurization is done at what? You have to answer for both. Pasteurization can be of two methods. One is Holder method, the other is a flash method. Flash method means higher temperature for lower duration, while Holder method is slightly lower temperature for longer duration. Yes, 72 degrees for 15 seconds is the best answer, so we will not be choosing this. And remember, 63 degrees for 30 seconds is useless. 63 degrees for 30 minutes would be the best answer. Okay, I'm so sorry, I don't know what happened. Some of them have. Severe conjunctivitis is caused by which organism? When you speak about severe conjunctivitis, severe ulcerative conjunctivitis, the answer would be Neisseria gonococci. Not seen in allergic pulmonary aspergillosis. What is the answer? Not seen in allergic pulmonary aspergillosis. See, when you say allergic, then I would not be able to say pneumonia. It is not an infection. Pulmonary aspergillosis has happened, but the reaction is allergic. So because of allergy, high levels, and it can happen with old cavital lesions, and pleural effusion can happen as a result. But recurrent pneumonia is not a part of the allergic pulmonary aspergillosis. Okay. Next, cryoglobulinemia is related to. The answer is hepatitis C. Remember, hepatitis C is related to two things. Cryoglobulinemia on one side. Also, it is associated with positive anti-LKM antibodies. LKM stands for liver, kidney, mitochondria antibodies. Okay. Which vaccine is not included in Indradhanush mission? The answer would be Japanese encephalitis. You know, there is a rainbow style for a picture. The rainbow style for the picture would be like this. And that rainbow speaks about 7 vaccine preventable diseases. Who are they? Diphtheria. This is the logo for them. Diphtheria, pertussis, tetanus, tuberculosis, measles, polio, hepatitis B. Japanese encephalitis is not a part of this particular mission Indradhanush. Okay. So I have rapidly done I have done actually 102 MCQs, 2 more than promised, and you all have been amazing students, and I would like to thank all students who sent me MCQs in the last 5 years. I would like to thank the internet sources, multiple internet sources where many MCQs were taken. So I wish there is a collection of all MCQs, because no MCQ belongs to anyone, and AIMS or PJ Chandigarh or JIPMAR or NEET, they won't be offering printed pictures, printed MCQs. So all the students from the internet, that is especially on Telegram and on WhatsApp, whoever has sent me a lot of MCQs, that is purely recollection based questions, right? Thank you very much. And all those people who have been here patiently, thank you so much for your kindness. And I hope this session has helped you somewhere, and I hope you will use this information in your exams. If any of this information comes in your exams, I hope you'll be able to crack it. Of course, out of 100 MCQs, 10 to 15 MCQs were moderate. They can be slightly this or that. They'll be like a cat on the wall. Either the question will be wrong, or the understanding of the question will be wrong, or the answers may not be having a clear answer. But out of 102, at least 85 questions can be short answers for your exams. And I wish the best for all of you. Thank you so much for all your prayers, and thank you very much. And on the Unacademy app, soon I'll conduct a special class. And for those people who gave me hats, thank you so much. And if you like the class, please put a like. And after the session is over, by evening, after 1 or 2 hours, please put a comment on that so that other people can learn from you. Remember one thing, the more good things we do to others, good things will come back to us. And if at all you have learnt very well, you are doing a good thing. Your learning is a good thing because you are doctors who will be the only barriers between life and death of many patients. So when you're studying, the force of universe keeps on watching it. I believe that the universe watches whatever your hard work is. Your hard work will come to fruition when it is mattered. So remember, your results, your PG seat may be slightly delayed, but never denied. You are going to be a postgraduate student, and that is what is my ultimate wish. I pray for the best for you. All the very best. Thank you so much. Good night. Okay, yeah. Thank you, Lavanya, Vinibal, Shubkamya, Silpa, Gryffindor, Hornon, Dinesh, Dayanti, Seshagopalan, Lira, Shubhakalyan, Laya, Shubhakalyan. Okay. Thank you. Good night.